available on our website for those wishing to view it following our meeting. Some practical points to start with in terms of the meeting. As usual, just to ask those presenting reports to take into account the colleagues will have read the reports. However, just to pull out perhaps some key highlights and to indicate if there have been any changes since the reports were drafted. We're going to take a short break around about 10:15, 10:20. And then again, I think around about 11:30, because we've got quite a long meeting today. So just to welcome colleagues who are joining us today. Very warm welcome to Mark Thomas, our Deputy Director of Finance, who is attending in place of Sally May, our Executive Director of Finance, Paul Blake, our Consultant Surgeon, and Sharon O'Brien, Care Group Nurse Director of Planned Care, will be here to present the listening story under item 3.1. Welcome also to David Jones, Intensive Care Consultant, and also Charlotte Goodwin, Lead Nurse from the South Wales Organ Donation Services team, here to present the Spotlight Report on Organ Donation and Transplantation, agenda item 4.1. Also, very warm welcome to colleagues from Llais Cymru, Daniel and Kerry. Good to see you both this morning. Thanks. I'm sorry we put you in the naughty corner. It wasn't deliberate. But we are short on space, as you can see this morning. So it is a cast of thousands. But very warm welcome to colleagues from Llais, as always. Matt Jenkins, our Regional Integration Director, is here. Matt, good to see you again. Matt is here to present the item under 6.5 on integrated opportunities on social care. And Rosie Cavill will be joining us, if she's not already here. No, Rosie will be joining us for our discussion under item 8.2 in respect of the update on Clamp Tristant Health Park. I think that's all of the welcomes to colleagues who are not normally with us. Lisa Curtis-Jones is joining by Teams, and Sarah James, our Deputy Chief Operating Officer, is joining later on in the meeting virtually for the Integrated Performance Dashboard item. Can I also welcome two observers for the meeting, Nathan Couch from Audit Wales. Nathan sometimes joins by Teams, but we've got Nathan in real life today, so very warm welcome to Nathan. And also to Helen Davis, a member of our staff, an infection and prevention and control nurse. So Helen, very good to see you this morning. Thank you for joining us. Apologies, as I've said, from Sally May, our Director of Finance, Getting Hughes, Chief Operating Officer, and from Anne Morris, one of our associate members. Moving on to item 1.3, declarations of interest. I've not been notified of anything. Is there anything that anybody needs to raise in respect of the agenda today? No? Okay, thank you very much. Item 2, the consent agenda. Just to focus on those things that are critical and those things where we need to provide the greatest focus this morning. You will have seen those opportunities that are placed under the consent agenda. Is there anything that needs to be brought forward into the main part of the meeting that can otherwise be left towards the back end of the meeting? Are colleagues happy having reviewed it? Okay, thank you very much. That brings us on to item 3, our shared listening and learning story. So can I welcome Paul? Sorry, Paul, I can bet just about see you. Very warm welcome to Paul Blake. Is Sharon joining you this morning, or she's been called to PCH? Been called to PCH, right? I promise also I didn't realise that. So very warm welcome to Paul Blake. Paul, I know you've been to the board previously, so very warm welcome to you again today. And this is the patient's experience of the implementation of robotic surgery. So it's great to be able to follow this up. Fantastic.
Good morning, everyone. Thank you for inviting me back again. Nice to see some familiar faces. Like I said, I'm Paul Blake. I'm a colorectal consultant based in Bridgend, but operating from here. And about this time last year, I came here cap in hand asking for an incredible amount of money, which you very kindly gave. And it's now to kind of give a bit of an update in the last 12 months. I've got a couple of slides to present, and there's a vignette from a patient as well to give you. But overall, today actually we're doing our 15th colorectal cancer operation. It's probably happening just now. There are 4 colorectal consultants now trained. 2 upper GI consultants have started, so they've done 5 gallbladders already. And the gynecology team have just finished their training as well. So we hope to be up and running 4 fully qualified teams in October. There are slides after, yeah. So we went with it's Cambridge Medical Robotics as a company. There are a couple of different robotics companies in competition. We went for a British-based company who have been giving us a fantastic pre and post introduction service. There's quite a laborious training program that goes with the introduction of robotic surgery. So there's 4 teams now fully qualified, and every time we operate, we have representatives from the team with us as well. In January, that was the initial team. Mahmood is a gentleman on the right in the Navy, so he's a corrective consultant here, and we've just come back from Cambridge after doing a 3-day intensive robotic training course, having done online modules, and that was the day of our first operation. As we've done 15 colorectal cancer operations. For those who haven't heard before, the benefit of robotic surgery is it's minimally invasive. We get far better view of what we're doing, which reduces complications potentially, hopefully. And because of such a small incision in the skin, post-operative pain is a big factor in the introduction of robotic surgery as well. To date, and I know surgery, there's always complications at some point, but we've had no serious problems. We've had no heavy bleeds. We've had no problems. We've had no one return to theatre. And we've had no one requiring an ITU bed. And an ITU bed is about £1,500 per 24-hour period, which is a massive saving already. And so far, none of the patients have had chemotherapy either. So we've done full resections in all the patients to date. Again, with robotic surgery, most of the patients are going home after 3 or 4 days. They've all been set out the next day. They've been eating the next day, which means a reduced risk of chest infections, pneumonias, atelectasis, clots in their legs, clots in their lungs. And we've had quite a number of young patients as well. And some of them have even returned to work. So there's an economic upshot as well. Yes, please. As there's 4 colorectal consultants, there's 2 upper GI, which means gallbladders, livers, hernias, and there's 2 gynecology consultants just starting their training out this week, actually. And then we got a clip from a lady who was a 70-year-old lady who had a rectal cancer, quite apprehensive beforehand. She agreed to a robotic operation, and this is her perspective. This is Mrs. Jones.
I was very complacent because at 76 I wasn't on any regular medication and wasn't sending off any tests. Obviously, I realised I had a problem and went and phoned the doctor straight away and managed to get an appointment that day. And from then on, things started moving, and I had tests and realised that an operation was vital. I've seen the doctor. They started investigation. I had camera and scans, and had a scan on a Thursday, and the following Thursday the team met, and Mr. Blake, a surgeon, rang me that day and told me that I needed an operation and he would operate robotic surgery the following Wednesday. So I didn't have time to think about it, but agreed. He explained the advantages, and I had no qualms at all about having robotic surgery. The operation was to remove a tumour from the bowel, and Mr. Blake also took away some lymph nodes and one of my ovaries, because there was a problem where it was, not that it was infected. I didn't have any qualms at all about having robotic surgery, and Mr. Blake explained that it would be less intrusive and that I would recover quicker, and that he gave me faith, and I decided, go ahead. And I would have to have waited a lot longer to have the open surgery, so it was no question, get it over with and let's get it done. Well, I recovered ever so quickly. I came out of hospital without any medication. In fact, I didn't have any on the Sunday or when I came out of hospital, and I'm not on any medication and haven't had to have any since. And people that have visited me can't get over how well I look and how quickly I've recovered after such major surgery.
So yeah, well, speaks for itself, really, doesn't it? A 78-year-old lady having major surgery, didn't require any analgesics at any point. Went home after day 4, and she's back to normal function. So not much more I can say. I think Mr. Jones has said it all for me.
Yes,
Thanks you all.
Thank you. Tom, I think I'll bring you on this one.
Yeah, I think I might pick up a follow up to why Blackadder was the next video lined up after. So, but I just want to say thank you to Paul. I mean, that I think he's underestimating exactly what they've managed to achieve. Having no complications that are serious in the first 15, you expect the complications to happen early on. Not to say there won't be any, but the fact that you haven't is astounding. And you can just see there from the patients what the impact it has. But I think I'd particularly like to point out to Paul, who's led this, but Mahmood and all the others, including the theatre team as well. They've all put in significant additional time on top of their contract. They're doing it in their own time, a lot of this training, because they know it's the right thing for our patients. And I think that really needs to be recognised here. And the impact is astounding. And thank you very much indeed from all of us.
Before I'm going to bring Karen in next. Before I do, a really quick question around the nature of the conversation that takes place between you and the clinical team and the patient, because I think some of the things that were said there, particularly around giving me faith. When you say to somebody, we'll perform this operation, but it's using robotic surgery, I imagine immediately you think, oh, good God, what's that? Yeah. So in terms of the training, the support, the staff to have that conversation, how critical has that been?
I always meet the patient a week or two in advance, and there's an ad hoc clinic, so there's no time pressure to sit down. And I always ask them to bring a relative or a friend or an advocate as well. And the first thing they'll ask is, will you be there? They think that the robot is doing it autonomously. They have to reiterate and say, absolutely not. Full team of people in the room. We're not kind of in a plane transatlantic from our phones. And I think people are becoming more aware of it because a lot of men with prostate cancer are having to operate. It's not such a novelty anymore. But yeah, we do explain to them and say, we're always there. We've looked at your scans. Not everyone is for a robotic operation, but you are. There's going to be 2 consultants. There's a senior anaesthetist in the room. There's nothing really different. It's pretty much the same as keyhole, but it's just with a robot. We need to get more precision, quicker recovery time. I haven't really had much opposition so far or resistance, but people will want to know that you're actually in the room doing the operation for them, because at some point we will have to. Something will happen. It's inevitable. You do enough operations, you'll have to convert at some point. Means open them up. But no, we are in the room, and if you give people time and tell them before, just bring questions, bring somebody with you. People just seem to quite embracing it actually, and people are quite pleased with the fact that there's a robot here in this trust, in this health board. I think it's a real step forwards.
Yeah, sorry, Karen.
Yeah, thank you. And it's fantastic. It's so good to come back and see the impact of that investment. Really, what struck me though was as well as all the brilliant things that you described, is the whole system benefit to this, because it seemed to be, that lady, she didn't wait very long. She was in and out much quicker. She recovered quicker. No medication. Presumably the follow-up. She didn't need an ITU bed.
Yeah.
All of that whole system impact seems hugely beneficial. And I think, I can't remember now from the business case, whether that was included as part of the business case. Was it that reduction in ITU time and clinic time and medication and all of that? I just think there may be even more benefit than we would have seen there.
That's exactly what I'm hinged on. That when I was here 12 months, pleading for resources, that's exactly what we were expecting. We were hoping to see, but hoping and then actually achieving are 2 different things. So it's really pleasant to achieve that.
In terms of evaluation of that, then how is that being done?
So we're part of there's a big UK-wide collaborative study now based in Oxford and in Aberdeen that we're part of. We're getting research. There's people doing MDs in Cardiff University that are now looking at robotic surgery. So there's lots of spin-offs, there's research spin-offs. We'll attract more registrars. Hopefully we'll get consultants coming to the trust. Registrars are asking us this. Do you have a robot? They know we have a robot now. Will you teach me? Will you train me? Yes, we will if you come to us. So in terms of retention, recruitment, research, kudos.
That's great. Thanks very much.
Ian?
Yeah, I'm just wondering what percentage of patients would be eligible for this sort of surgery? Because you said not everyone is. So I was wondering if we're going to, look into the future, improve efficiencies and whatever. How many patients can we put through it? I was thinking
probably about 2/3 to 3/4. So there's a general rule of thumb is if you can have an operation keyhole, you can have it robotically. The things that limit keyhole or robotics, if somebody's had lots of operations in the past and we've got to get a lot of scar tissue on the inside, and then we can't move things like we normally do and have to do an open operation. We wouldn't do an emergency. With an emergency, there's too much time setting it up and so I say laughing about this, but no, if it's a planned elective surgery with 2/3 to 3/4 of cases, we would hope to do it.
That could be significant efficiency.
Yeah, well, you're right, and that's my next project now. So at the moment, we're doing it almost on an ad hoc basis.
Yeah.
We're pushing for, we do the steering group is to get a designated day of the week, because there's 4 teams and we don't want it to be just using when we can, or we get an opportunity. We want it to be a normal everyday occurrence of people having robotic surgery. So that's my next task.
Good. No, great. And just leading on from that comment, really, and then Carolyn's point about the whole system. Obviously, we need to ensure that we've got good uptake of our screening in this case, so that people are coming in early. We're detecting people early enough to benefit from it.
Yeah. I was hoping to get Mrs. Jones to. I know there was media interest as well. There was ITV interest at one point. Mrs. Jones, she's a very erudite, switched on lady. She's quite high up in the South Wales WI. So she's well lady, and she would be perfect to talk about screening.
Thank you.
Yes. And she actually wants to make a donation to the trust after her operation.
Charity then.
So if we're just building on that, you're absolutely right, Paul. You know, we've been had a couple of false starts, haven't we, on doing some TV with this, but ITV are still really interested in picking this up and doing something with us. So they are still on the kind of waiting for that call. We managed to set up someone who's feeling comfortable to do this, because it's quite a thing to talk about.
Yeah.
Your health in this kind of slightly intrusive way with TV. It just goes to show, I mean, it is a really, it's a really positive story as well. The more we can shout about this, not just in terms of our reputation with our patients and the public, but as you say, Paul, in terms of our reputation with the wider kind of potential clinical workforce as well, is really fantastic in terms of attracting new staff to come and work with us as well, because we are that kind of cutting edge. So we are keeping on with ITV, but they're still on the hook, and we'll keep them there until such point as we find a patient who's suitable and happy to live.
Okay, no, we'll do that. Yeah.
So just pick up on the bowel screening comment that we had there. It was included in the quality and safety report that we took, but we were written to by Public Health Wales to compliment us on how well we were doing our bowel screening. We were one of the best people in Wales for it. So it links quite nicely with that.
Well, I've operated recently on a lady who's 52, and she was one of the age limit for bowel cancer screening was recently been dropped from 55 to 8. She did it just randomly, and she's been found to have a tumour and operated on. Unfortunately, it wasn't robotic, but this is a 52 really completely coincidental finding, and she has agreed to go on the media. I've spoken to her, and she would, and again, she's a very, very well spoken. She could hold her own in front of the camera. So if you're interested, but I can't tag the robotic surgery onto her, so it would be a separate issue.
Yeah, but thinking of Philip's point about the screening, I think that's really useful, particularly someone being, that young as well. I think that's a really good case study to grab hold of. So
she would be happy. I've spoken to her about it, and she would be happy to go in front of a camera.
Yeah. Right, we'll put that maybe offline.
Yep.
Any other questions or comments?
I just think that it's really nice closing the loop, really, Paul, for you coming along today, because I think why we wanted to get that story in, because I think as board members will know, if you say about a year ago, we've taken the decision to fund this. But I think what it shows is, you want to be at the leading edge of these things, don't you? And these are the things, as you say, that will start to become just commonplace now moving forward. So it's really good that we're in a place where we can start to be able to showcase what we're doing, and also hopefully improve attraction of clinicians coming to work here, but also giving confidence to the communities we look after that we've got really cutting edge technology going on within CTM, and that we're able to provide really good outcomes for people, which is what we're all about. So it's a really, really positive story, I think. And thank you for all the work you've done championing this. Because I know, it probably felt sometimes you were pushing water up a hill, but we've got there. And the testament is now we're seeing patients going through it and getting really good outcomes, which is really great to see. So thank you for all your time and support as well.
Thank you for your investment. Yeah, thanks for seeing us.
Thank you. On behalf of the board, thanks to all for coming this morning. Really good to see you, and thank you for the updates. I'm sure we'll hear more updates as the months and years go on. But thank you very much. Cheers. Thanks. Okay, we're going to move on to item 4, and this is in respect of organ donation and transplantation and the performance of the health board. Dave is here to take us through a presentation. Dave, I think your colleague has Victoria, stuck in there. Very warm welcome to Victoria, who's here to present this item with Dave as well. So really good to see you. Thanks, Victoria. Great.
Thank you.
And Dave, over to you.
Morning. Thanks so much, everybody. My name's Dave. I'm one of the intensive care consultants who works in South Board. But one of my roles nationally is I'm the regional clinical lead for organ donation for South Wales. Thanks very much to Karina and Vicky, our embedded specialist nurses for organ donation, for preparing these slides. Yes, that's fine. So just to meet the team, Victoria and Karina are our specialist nurses for organ donation. They're from an acute and critical care background. And as part of the specialist nurse training, they have advanced communication skills training. They hold an honorary contract with the Health Board as our embedded SNODs. And one of their roles is the education and promotion of organ donation within the Health Board. But they also cover the on-call. So if there's a donation going ahead within Wales, within the southwest, because they cover a huge geographical area, and because they work in clusters, they may even be as far as the West Midlands or Birmingham, Coventry when they're on call. So they're very busy people, but spend a lot of their time working within the Health Board, embedded within the critical care team. We've got 2 clinical leads for organ donation within the Health Board, Jay and Naja Hassan. Their activities are funded by NHSBT, and they have an annual appraisal with myself and Joe, who are the regional leads. And there are local points within the Health Board for any other organ donation activity. And they're the project investigators for the SIGNET trial, which is a national randomised control trial looking at the role of statins for cardiac donation. Okay, thanks. One of our key team members is Adette Ward. We're the first health board in the UK to have this role. So Adette lost her husband, probably getting on for about 10, 15 years ago now, who went on to be an organ donor. And she's really taken this role on in supporting families who are going through the donation process. Could be something as simple as just sitting with them, explaining the process, providing cups of tea, sitting with a patient while they go to while the family go home and have a break, have a shower, that kind of thing. And she complies with our expected code for volunteers and represents families on the organ donation committee. The organ donation committee is chaired by Helen. The team meet quarterly to look at any performance, any stakeholder engagement, linking in with any national projects which NHSBT are doing, and provide assurances via the Quality and Safety Committee. Thanks. And then the regional team is myself and Joe and Charlotte and Bethan, and we have 11 SNODs and specialist nurses and 14 clods. We also manage the regional fund, which comes from NHSBT and Welsh Government, which sits about £85,000. So any organ donation promoting activities, education, equipment that we need to facilitate donation can be applied for via that fund. The organ donation process is probably one of the most complex clinical pathways in the NHS. It starts with a patient being admitted to hospital and then getting to ICU. So to be an organ donor, you have to be intubated and your death is occurring in a controlled way. And then there's the checking of the organ donor register, a decision that death is going to be imminent on intensive care. And then the specialist nurses review the medical records, discuss with the transplantation centres. Then we discuss with the medical examiner and the coroner, and then approach the families to see whether they consent. And then if we get consent, we move on to that's great, thanks. Following death, then we will try and optimise the donor as much as possible. And then at the same time, the recipient at the other end of the process, who will be receiving this organ, will be mobilised to their hospital to get the theatre slot. So when the organ is retrieved from, say, Royal Glamorgan Hospital, there's a team of couriers waiting outside to take the different organs around the UK. So as you'll all be aware, the legislation across the UK has changed over the last, getting on for 10 years. There's very little political objection to this, which is pretty much unheard of, and it passed through the Commons without a vote, really, got through on the nod. Thank you. We work to 2 big documents, the transplantation plan for 2030, which is meeting the need, and the key point in that is donation becomes an expected part of end-of-life care, when before it was a usual part. And we hope that all families will expect a conversation about organ donation as we approach the end of life. We lost 2 years of this plan because of the pandemic, and was on track for the 2030 plan. We also work with Welsh Government quite closely via the Welsh Transplant Advisory Group, and we've got 6 main targets which we benchmark all the performance of the health boards against in matching that. This graph shows the referrals and approaches and the consent rate and proceeding donors from the different health boards across the UK. As you'd expect, Cardiff and Vale as a trauma centre, as a cardiac arrest centre, will have more numbers, and they're what's categorised as a tier 1 centre. And then looking at the Cwmtaf Morgannwg data, this is an incredible performance by the clinical team. 100% testing, referral and SNOT present rates when we're diagnosing death used on neurological criteria, and 100% referral rate for patients who are going to die of circulatory death. A slight caveat to the SNOT presence. So if we know that a patient has opted out of the organ donor register, we don't necessarily in Wales mobilise a specialist nurse to have that conversation. So we would know before we approach a family. But the way the data is presented UK-wide, it does look like Wales has dropped off there. Thank you. This is a neurological death testing. As you can see, over the last couple of years, 100% testing rate for patients who meet the criteria for neurological death testing. There will be sound clinical reasons why we wouldn't involve neurological death testing, and that will affect the data. So I just suggest some caution interpreting that 100% is not necessarily a target if there's a sound clinical reason. And the reason it's dropped to 25% is I had a patient who I was not comfortable to diagnose death using the criteria, and I think justifiable clinical reasons for not doing it. That shows a persistent increase and stabilisation of our referral rate. So all patients who are potential donors get referred to specialist nurses for organ donation. Thank you. And we have a 100% SNOT presence rate within this health board as well. And that's testament to our embedded SNOTs who are very present and active across the 3 sites, listening into our SITREP calls to hear so they can mobilise to be in the right place. And as you can see there, the dark blue shows a number of transplants associated with a number of donors. So one donor can go on to say give up to 12 life-changing or life-saving transplants as we go. Thank you. So looking at the preceding donors over the last financial year, thank you. We've had 19 referrals to the specialist nurses. That resulted in 7 donations going ahead, which has led to 14 patients receiving life-saving or life-changing transplants as well. So since the law changed, the question we always ask is what difference has it made? So following the change of legislation 10 years ago, we did see an increase in the number of consent, in the amount of consent which was being gained. But as we move on, you'll see that as the time has progressed, the consent rates have started to drop off, and this is a bit of a cause for concern within NHS bone transplant. Thank you. So looking in South Wales, the consent rate is currently sitting at about 52%. And if we move to the next slide, please, we can see within this health board, the consent rates are sitting at about 29%. Now, there'll be lots of reasons for this, which we'll come on to shortly, but I think part of it is the amount of knowledge within the community, across, well, all communities across the UK, about what that change of legislation has meant. Because I think a lot of people now think that the fact they haven't opted out means that they have by virtue of that opted in, when in fact we can assume that they don't have an objection, which is very different to the powerful decision to donate. So if we can get more people registering to be an organ donor, we're taking away that grey area in the middle of no decision, where the law suggests that they don't object, but that's very different to, yes, I do want to be a donor. Thank you. So there'll be lots of reasons why our donor pool has changed over the last 10 years. As Paul was saying earlier, we're getting more cancer diagnoses, which is a great thing, obviously, But with that, the ability for patients who have cancer or have previously had cancer and haven't particularly had the all clear may preclude them being an organ donor. The pandemic changed a lot of our donor pool, so the sort of patients who would be having their out of hospital cardiac arrests and then going on to be an organ donor are no longer with us because unfortunately COVID affected them. Pre-hospital care has had a huge positive impact for patients in their survivability, but the patients who were previously having traumatic injuries from road traffic accidents are now surviving, so they're not becoming organ donors, and overall ITU is having better outcomes. Thank you. And then there can be lots of family reasons for why they don't want to proceed with organ donation. As I touched on earlier, it's such a complex process. Once we got to the point of death, saying to the families, well, we'd like to continue them on a ventilator for another 24, 36 hours, while the transplant surgeons mobilise to the hospitals, can just be too much for family because they're absolutely exhausted. There's no major religions which have a religious objection to organ donation, but there are cultural reasons why they may not, or they may misunderstand what organ donation means. And then delay in admission and length of stay and overall satisfaction with the NHS may reflect why families are saying no when it comes to this final stage. We've got two YouGov polls here which shows a divide in satisfaction within the NHS. This is across the UK. Next shows the satisfaction within Wales as well. So I think it stands to reason that if you've had a poor experience leading up to the death, families' views of the service at that point may not be amenable to for donation proceeding. Great, thank you. This graph shows the organ donation decisions registered across the UK. As you can see, Cwmtaf Morgannwg has one of the lowest opt-in rates in Wales, but it's also got the lowest opt-out rate as well. So what this tells me is we've got a huge population in this area who just haven't registered a decision one way or another. They may have had a conversation with their family, but that's difficult to really explore and pick apart when you're having that conversation with a family. So anything we can do as an organisation to increase the number of patients registering that positive decision to donate is going to have a huge impact and on the number of donations and consent rates that go ahead. For example, the specialist nurses will have all of that data on their iPads of when they registered with the DVLA, when they bought a new Boots card, when they got a new passport, they signed up to be an organ donor. So if the families at that point say, oh, we don't know, well, Vicky can say, well, look at this, 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 and this. Your loved one did want to donate. But what we have is a population who are just not doing it one way or another. This graph shows where most of the donations come from. The DVLA provides a huge number of donations, and GPs providing about 6% of that, and to see Boots and online. So every now and again, there's this drive with a QR code for people to sign up. Thank you. So the Organ Donation Committee priorities for this year is lots of community engagement, lots of public awareness. The team attended the Eisteddfod when it was in Pontypridd. It's Organ Donation Week this week, and there's a lot of activity going on with the wider community. They've done some work with the local religious groups as well as working with the Health Board's communication team to raise the profile of organ donation for staff, patients and their families. And one of the recipients in Aberdare has provided a blog which is now going out on the social media platforms and on the websites as well. Thank you. So measuring success is based on a QR code which is linked to the activities which are going on, so we can track how much impact these are having. And target is get an increase of 500 registrations within the health board. Because as I said, we've got about 60% of our population who haven't said one way or another what their decisions are about organ donation. The future plans, and this is more of a national project, is having something within the NHS Wales app so people can register their decision linked to their health record. doing some blanket advertising, so things on TV, billboards, very broad brush things, but then using algorithms on social media, Netflix to target adverts, using the tracking on that, and then hopefully working with the government to do some opportunistic things. So when you're getting your life insurance done or you register your will with a solicitor, there's an organisation thing. And then possibly in the future working with the GP contractors to look at QOF points linked to the amount of registers they do. Okay, thank you. So what we like to ask from the Health Board is to continue the excellent work which is going on in supporting NHSBT activity, having as much wider stakeholder engagement on the organisation committee, increasing our activity within tissue donation, and continuing to work with the communications team and getting some memorial artwork out of the NHSBT fund. And these are some examples of the things that we can provide to the health boards and hospitals and trusts across the UK. So, as I said, it's Organ Donation Week this week. Lots of our public buildings are being lit up in pink, and there's a race for recipients going on across the UK to raise awareness. I think as a clinical team, we've taken things as far as we can go. We can't do much better than 100% referral rate, 100% not presence rate, but it's really going to be a case of engaging with our communities for them to register their decision to be an organ donor. Thank you very much.
Thank you, Dave. Thanks for the excellent presentation. Really thought-provoking, and thanks for the data. I've got a whole range of questions, but I've got a particular interest in this sphere for a number of reasons. But I'm going to come, we may have to go for coffee because it may take a bit too long to get my list. But I've got one question I'll throw you up. Garrett, go on.
Thank you very much for your presentation. Thank you, Chair. I thought it was a very significant change in our national outlook 10 years ago when we moved to this, and very supportive of it. We are a nation of organ donors, and that was something I thought is a wonderful thing that we could say to the world, that by default we are all, unless we wish to opt out. Has the change been, it's a change of emphasis in the conversation, and is what you're saying that change is nuanced or perhaps too subtle to have had any pragmatic change in the individual conversations that go on at the point when donation is discussed, which may explain why on the surface it doesn't look as if an awful lot has altered since 10 years ago.
I think the thing that happened with the change of legislation as well is there was a lot of media attention with it. So it was on the news about the change of legislation. It was associated with a huge advertising campaign as well. I think one of the most effective ones was when they superimposed somebody's voice and mouth onto a donor, and Speak for Yourself was the driver of the campaign. That kind of fell away.
It was 2018, and then we seen a big peak actually when the law changed between 2015 and 2018. We were the best performing team in the whole of the UK for consent rates, and as that media campaign fizzled out, our consent rates slowly teetered down, and actually now we're performing at one of the lowest consenting rated teams in the UK. So, but obviously after us then, England and Scotland changed their laws, and they are now seeing the big peak of consent rates that we seen back then. I think with families, when we are approaching for donation, it is that there is this grey area about communities believing that the law change kind of made the decision for them. They think that they're already on the register, even though they haven't physically registered a decision. And then when... Pardon?
Isn't that the case?
No, so you have to register to be on the register, basically. So if you have made registration, when I search someone's details, it would come up with nothing, it would be blank. So I go into that conversation with the family, presuming that they have no objection to donation, but I haven't got the physical evidence to support that they have made a decision. And I think that's where families lack that certainty then of that decision making, and then are inclined sometimes to say no because they think if I do nothing, then it's better than doing something and possibly not doing the right thing for my loved one.
No, I mean, I think Garen, thank you very much, Chair. I think Garen's point about the nuance is important. This is clearly a really sensitive area, right? And what we've seen in terms of road traffic casualties, not only in terms of COVID, but also the 20 mph restrictions as well, have actually reduced those by a third. They're planning to evaluate that, and I think it's getting the messaging right around, and that's an opportunity actually to restart those conversations as well, because there'll be a lot of advertisements around that too. So I'll pick that up with colleagues in Public Health Wales who are leading the 20 mph work to link right in.
Thank you.
Rachel?
Yeah, just coming back to the conversation about the patient's sort of explicit consent and then the family position. So my mother died 3 years ago and she was on the register. We didn't know. But at the point where we were asked, for our permission, we said, my dad was like, no. And then the person I spoke to said, well, your mother was on the register. So I said, well, then that's what she's decided. But my father was adamant. And that was really difficult to try and square that off. So I suppose it might sound like a basic question, but if the patient has consented explicitly, why is the family then asked?
Because during life, when somebody's alive, nobody can consent for another adult. When they die, the law's slightly different, and then, for want of a better word, that ownership would sit with the next of kin, and then there's a hierarchy for that. I'm not aware, and I'm pretty sure that NHSBT have never challenged legally a family to say that they made this decision during life. We're going to take you to court to challenge this, as they do in the United States. Because the level of consent is it's not actually you're giving consent to be an organ donor, you're registering a decision, which is different than to signing a consent form to have surgery. I think it would be more legally robust if, say, for argument's sake, myself had an advance directive to say, if I'm incapacitated, I'm going to die. If my family try to stop me being an organ donor, feel free to take me to court and I'll come back and haunt them. But at the same time, we've got a duty of care to our families as well. And as long as the decision is the right decision for them and their loved one, having that evidence to say, well, they have made that decision during life, sometimes can tip the balance in favour. But as you'll well be aware, it is the most upsetting, traumatising time for families. They've been through the ringer during their time on intensive care, and they've just got decision fatigue by the end of it. As Victoria says, at that point, it's often a case of, we're out.
I mean, you've said how important public awareness is on this, and it's interesting that there was the big national kind of campaigns that you mentioned, which were really good. The fact they dropped off, the difference that's made is, the cause is really clear to see. So it's really important that we as a local team then pick up that slack and occupy that space. And I think this year, I think for Organ Donation Week, we're doing more as a comms team overtly, than we've done in previous years, certainly since I've been here as well. I don't know if you've been involved in the piece that my team have done with Reece and his family. Yes. So there's a piece going out, I think it's ITV broadcasting it tonight. So which is Reece's story, which you mentioned there, the chap who's had 2 heart transplants. I understand his son is also, the potential to be impacted in the same way as well. So those kind of stories are really, really important. Local people who can talk about the impact on them and their families going forward. But I also think it's really important. Organ Donation Week is what it is. It's a week. It's 7 days, and then we move on to the next thing as an organisation, and public awareness is taken on to the next awareness day. And there's awareness days for everything and anything. So it's worth thinking about how do we keep that momentum going and that engagement with people beyond Organ Donation Week as well. So keep on finding those case studies and talking about those case studies. The media will always be interested in those kind of stories which are told on the heartstrings as well. So there's always opportunities for us to kind of, I think let's keep this relationship going, try and keep this high on the agenda as well. And yeah, you know, I know my team were really happy to work on the story because it's a really impactful thing. I haven't seen it yet. Also, it's out tonight, I think at 6:30. I think it's 6:30. So
it's on the ATV regional there.
yes. So yeah.
No, your team have been really fantastic, Joe, especially for getting the ball rolling and kind of with Reese's story, it started as he was going to write a blog, then he wrote a dissertation of like 10,000 words of his whole journey of transplantation. It's really lovely. But that snowballed thanks to your team and ended up obviously on the regional news, and we wouldn't have been able to kind of get their insight into it and get them to pick it up without your team. So
and just a shortened version of Reese's dissertation is on our website as well, so it's really worth having a look at. It's really powerful still.
Okay, before I've got a couple of people who want to come in at this point, Rachel, Helen, and Ian. Before I bring them in, can I just say that Lisa has put something on the chat on the Teams bit. So apologies, Lisa, for missing that. Lisa said, I assumed, obviously wrongly, that as long as I didn't opt out, then it was an automatic donation due to the change of law. So the comms program, I think, would greatly assist. Go back to your point, Sam, about how we elevate this and explain it to people, particularly if we've only got a 29% consent rate. I don't know how that compares to pre-legislative change, but that seems quite.
With those consent, because they're relatively small numbers as well, it doesn't take much to
Yeah. Rachel?
Yeah, just I suppose wrapping up the point about the reach, how do we support the health board comms team in the communities through our organisations, through the making every contact count? I can't see how we're going to get that reach unless we are bringing non-health professionals into the conversation and giving them as much information as they need to be able to say to somebody, have you thought about this? And if you would like to, this is how you go about doing it, and support them wherever possible. So I suppose an offer, I'll probably get shot for this, but an offer on behalf of other third sector organisations who do come into contact with people of all ages. We can make that making every contact count come alive with this sort of thing by promoting, and I spoke to Victoria about this earlier in the year. Yes, so happy to do that.
Oh, sorry.
So what I was just following on Rachel, but I was going to say that's exactly the same thing, Rachel. We've got great networks now with various community groups, voluntary sector groups. I'm just thinking we run regular forums with all those groups. It may getting you, Dave, along with colleagues to talk about this and actually asking them, as you say, Rachel, to do some of that sort of communication for us, because often we find in lots of areas it's the most effective way to get these messages out is to get people in those communities having that chat in the local voluntary sector group, or Dennis has got her forum there with 50. There's lots of different forums out there that we could be out there getting these messages, because I think what this conversation has highlighted is people aren't really aware that they've assumed they're automatically on the register because we passed the legislation. You still got to proactively go and register, and I think we could perhaps do a bit of a campaign using that voluntary sector groups locally, which would be
myself and my colleague Crean, actually Rachel, as sort of headlined us to some other volunteering groups, and we've got a health and wellbeing forum that we're presenting at in November. But it is difficult for us, on top of our on-call activity, our embedded presence, to know what is out there. So we do really rely on you guys feeding it into us where we can be, and if there's any opportunity to support public engagement, I guarantee that we would be there.
Yes, Helen.
Thanks very much. Thank you, Dave and Vicky, for coming today. And just a shout out for them and their colleagues and the work that they do, and that Corinne does as well. I've been involved with some of that. I feel like I'm learning a lot from them. They are real experts in the field. But mine is a plea to the board, really. We talk about, people can do this, people out there. But we all think, all of us, about what we can do to help to make a difference as well. Think about going on the register if you're not, and talk to your families about it and advocate, because between us, we can influence lots of people. They might not be all in this board area, but that can make a difference. And, one person on the register can save someone's life. My family benefited from support around an organ donation issue, and my cousin was killed and his organs were used for donation many years ago. So the conversations that Rachel just talked about, I've been through one of those, and the staff who were involved in that made such a difference to that happening, and to his family who've lived afterwards with the benefit of knowing that he helped 6 people. And you cannot put a value on what that means for families afterwards too. So, yeah, can you all go away and think about it?
And I think that's right. And I think also we employ 13,000 staff.
Yeah.
So actually, there's something about, do even our staff in our own organisation understand some of this? And we could do something proactively. What did we talk about yesterday about, we've got everyone coming in for their flu vaccinations and things. Could we be using that as a touch point to actually highlight those sorts of opportunities? So there's lots of places we could be sort of helping raise the profile. So that's really good. Pick that up.
And Lisa has just said now on the chat, so perhaps local authority comms teams could also link into this.
Yeah.
Ian, do you want to come on this?
Yeah, I'll be quick because a lot of people have said what I was thinking already. And that's this confusion on the law change. I definitely think most people think that they're already registered because of the law change. I was. And I thought I was registered before, but I don't think I am now. I'll go and check when I go back. But I think most people are like that, and or evidenced by the data. So yeah, in any comms campaign, I think that issue is the main one, as far as I think.
Yeah, just a really quick point. In terms of the wider strategic link regionally and then back to government, what conversations are taking place around infrastructure and support? The reason I'm asking it is, when the laws changed and leading up to the law changed, other countries were highlighted as best practice and showing the reason why changing the law was necessary. Spain was the country that the government focused on, and they focused on it wrongly because the law in Spain changed in the 1970s, but nothing changed until the 1990s. And the reason for that was they set up a national infrastructure to coordinate donation and transplantation. And Dr. Rafael Matazan, who headed up the Spanish system, said to us years ago, the law made no difference. The big difference was a change in culture, financial support. He said, we've got more intensive care unit beds than you've got. We've got a fast ambulance service. Those sorts of conversations around capacity and infrastructure and training for staff to have what are very difficult conversations was, in his eyes, the biggest shift. And I wonder again, what conversations are being had around that to make sure that now with the law change, they do all of that really intensive support work to make sure that in having those conversations, people feel more comfortable to approach a family where death is imminent. So I'm just wondering, is that part of the conversation going forward?
Yeah, so we're using some of that £85,000 to employ an advertiser within NHSBT within a Wales team as well to do a targeted advertising campaign in that. As you said, Spain's got one of the highest number of critical care beds in Europe, whereas Wales has got one of the lowest in Europe. There's a cultural change to be made amongst clinicians for them to understand that you're admitting patients who may not have been previously admitted to critical care because that individual patient's chance of survival was minimal or even 0%. But the fact you facilitate the donation, this is now a life-saving thing that you're doing. Because we're now working more collaboratively across critical care through the network, there's no objection from anybody to say transferring a patient from Merthyr to Swansea or Cardiff to facilitate organ donation. And then in terms of the SNOD workforce, especially in Wales as well.
Yeah, the difficulty we have, so there's two of us in contact, which is really lovely actually, but we've still got 3 sites to cover, our on-call rota as well to cover. So our embedded presence can seem quite limited at times. There's no expansion to that at the moment. I think they feel that because the service is running well and we are hitting our goal targets of 100% referral rate, no missed referrals, SNOD presence is good. There will be no capacity increase to specialist nurses within contact, but there will always be 2 of us. And that will continue.
But I think turning this into a positive around how do we persuade people to have that conversation with their families, but also to become positively on the register, accepting the fact that they want to donate, I think is something that we need to be better at, because for me, that altruistic gift, I think, is something that is far better to talk to people about than, they haven't opted out, we're not quite sure what their wishes were, and then just putting it back to the family. And I think, that was part of that discussion after the law change. It was getting families to talk about this so they can understand individual wishes. And I think if we can shift that narrative and then this being more of a positive action by people as opposed to just something that's in the negative realm, I think it's more likely to have an impact.
And the other thing, which is going to be done as a trial in terms of communicating with families, is something called the SEED project.
Yeah.
So the way we do it now is we encourage people not to mention organ donation unless a specialist nurse for organ donation is there. But what we're looking at now is, because nationally we're trying to make it an expected part of end of life care, when we've got a family and we've admitted them on the first day of intensive care and they say, well, what happens next? Just throwing it up out into the air of potentially organ donation, but we're not going to talk about that now, may nudge things. And as I say, the research team is still working through with our, our psychologists and people like that about how well that will land with people.
Yeah, sorry, then, Eva.
Yeah. Catherine.
Just really quickly, just wanted to say thank you as well. I'm just wondering, you sort of mentioned about the GPs and primary care, and obviously most people are signed up to a GP, and I do think there's an opportunity there to get the messages out. And I know that Dave Miller runs the CPD for GPs, and there might be an opportunity for you to perhaps try and focus on there as well and try and get their buy-in as well. So that'd be great.
Okay. We could spend, I think,
Yeah.
it's really important, and I certainly appreciate the challenges in that conversation that staff have with families at the most difficult of times. So thank you for coming in this morning. Fascinating, and I think I may pick up with you separately anyway, so I've got some other questions that might be helpful. But thank you very much for coming in. Thanks so much.
Thank you.
Okay, we're going to move on to item 5, and I'll turn first to the chair's report. It's just for noting, and there aren't any further details in my report that I want to highlight. I think it's fairly self-explanatory. Things have been moving at quite a pace in terms of the changes in government in recent months. We've had Lord Darcy's report in England, which shone a spotlight on some of the challenges there, but the challenges there, I'm afraid, will be equally applicable here. And of course, the UK government is now talking about a 10-year plan. So I'm sure that's something that we would want to reflect on in Wales as well. One of the things I just want to flag, and I think this is really important, next week, so in addition to this, next week is when we launch our staff survey. And I know we were discussing this week, Carol, with our leadership group. It's really important that we as a board do everything possible to support our colleagues in motivating, encouraging, well, we're not sort of coercing people, are we? But we're offering some teas at Starbucks. I think is a brilliant way of also saying, look, spend some time filling in the survey, and there's a free coffee at Starbucks for you for doing so. Hopefully that may motivate some people. But last year was a huge effort. I know board colleagues did a lot to help colleagues around CTM, stood in the foyers of our hospitals, having conversations with staff. Please find out how you can get involved. Talk to Harold and the team. But it'd be great if the board could be supporting colleagues over the next couple of months to up the return rate from staff in CTM, because the more we get back, it will help us. It will help Harold and the team. It will allow us to be better at what we do for our staff. So it's really important that we highlight this and give this some airtime.
I just wanted to say we're running a series of road shows on sites just to do exactly that, to encourage people to complete the survey, share the QR code, give paper copies where we need to. Anybody who wishes to attend those to help us to do that is very welcome to do so, whether that's execs or IMs or otherwise, and send those dates around.
Yeah. Thanks. Just a couple of things to flag at the tail end of my report, and that is the use of the common seal. The board is being asked to ratify the use of the seal in respect of a contract that I signed recently, and there's chair's urgent action in respect of the COVID-19 inquiry as well, and further chair's urgent action in respect of the Joint Commissioning Committee EMERT's judicial review. So unless there are any questions on the report, can I just ask colleagues to note my report, but also to approve the, well, firstly to endorse the fixing the common seal, but also to approve the chair's urgent actions highlighted in the report. Thank you very much, much appreciated. We'll just move on to the action log. It is for noting. If I can just say that a number of actions are being proposed for closure. There are a number which remain in progress relating to the scheduling of topics at future board development sessions, and discussion on these was held at the executive leadership group this week on Monday. The action log will be updated as a result of those actions agreed. So any comments on that? Patsy.
Just a quick question on 3.1. I just wonder if the board will receive an update on what systems of shared learning has been put in place with the local authorities. It's proposed for closure and it reads as if it won't come back here and close that loop. So I just wondered if something was going to come back to demonstrate what's been put in place.
Yeah. Patsy, we'll come back to you on that. Gareth will look into it. We'll come back to you on by email. So okay. Yeah, okay. Thank you. Okay, colleagues, happy to note the action log. Thank you very much. Okay, 5.2, the chief exec's report. Thank you, Paul.
Thanks, John. So my report's there for your information update. Just to highlight a few things. As always for this report, just to remind everybody of the escalation status of the health board, so you'll know that we're in enhanced monitoring, planning and finance and targeted intervention for performance around waiting times. I'm pleased to see that there are some improvements that are now starting to play through into our performance, particularly around our performance in mental health and CAMS, and that's been noted by colleagues in Welsh Government. So thank you to all of the colleagues in the mental health team for a considerable amount of work there to improve significantly the CAMS performance. We'll come and talk about later on in the performance report, but obviously there is still a very big focus from Welsh Government on performance generally, particularly around the elective care, waiting times and cancer. Cancer remains a priority for us, and there are a number of actions in place around that, as there are with emergency care. The next tripartite meeting of Welsh Government with Audit Wales and HRW is in, I think, November. There's been feedback from colleagues in Welsh Government that they're particularly in relation to our planning and performance and finance, that they would want to see potentially a de-escalation of that, given where we are with our financial plan. But obviously that remains under scrutiny, and we'll see how that plays through in the next couple of months. Also within the papers, we've attached the accountability conditions that were part of the confirmation from Welsh Government of the approval of our plan for this year, and you'll see in the paper the details of the accountability conditions that are part of the confirmation of that plan for this year. So you will be well aware of many of those areas, particularly obviously the need to de-risk and continue to deliver our financial ambitions, the focus on regional working, and supporting the national programme around value and sustainability. There's a national group chaired by Judith, which looks at the value and sustainability agenda across the whole of NHS Wales. We've aligned internally our own programme of work around those national work streams to make sure they're sort of read across to the national programmes, which is good. And there's also a piece of work I know which Dom's heavily involved around the HIT work, which we're also working on. So all of those areas on the accountability conditions are being progressed. Lynn's going to update on the acute services plan later, so I won't give more detail. We can pick up that later. Also, just to note in the report that the work on maternity and neonatal services at POW is currently in progress. So we have got the decant situation going on with maternity and neonatal services being taken out of POW temporarily and being deployed, women and families being supported to give birth in other facilities within CTM, but also neighbouring organisations. I think it's fair to say there are some operational challenges with that, as you can imagine. We're effectively running with one less unit at the moment, so that does put pressure on the particularly unit up at PCH, where many of the women who have chosen to give birth elsewhere have gone up to PCH, probably more than we were expecting to go to PCH. So that is bringing some operational pressure on PCH, which we're managing at the moment. I know Greg and Suzanne, our Director of Midwifery, are currently juggling some operational challenges related to that. And we're also only, I think, back today having a conversation with Cardiff and Swansea colleagues about any more they can do to try and support, to try and divert some of the work into those facilities as well, because I think PCH, it's fair to say, is pretty full at the moment, and obviously we need to make sure that the services up there are kept safe as well. So that's something that's being proactively managed on an ongoing basis, and we're also going to update widely on POW later on, more briefing about some current states issues down at POW. Also, just to say, JCC, the Joint Commissioning Committee, as you'll know, that's been in establishment since April, and Abby Harris has been the interim chief commissioner there. Abby has been successful and is appointed as the chief executive now of Swansea Bay Health Board, and will be taking up that post at the end of October. So that leaves a vacancy in the Joint Commissioning Committee, and that advert is out, just about to go out any day now. So we will be out to a advert for that. Obviously, reminding everybody we're the host for the Joint Commissioning Committee. So we are involved in that recruitment process and are supporting Ian Green, the chair of the JCC, in that appointment process. Also, just so another bit of news that wasn't in my report was that Lauren, I'm going to embarrass Lauren now to say, Lauren has just been given a visiting professorship at the University of South Wales, which that's a really good endorsement, I think, of the relationship that the Health Board has with the University of South Wales, which is really positive. But I think also really important that for the AHP community and health science community, that we have somebody now forming that liaison into a USW, particularly given many of our AHPs train at University of South Wales. So I think it's really great that we've got someone from the Health Board in there, hopefully scooping up the AHPs coming out of training. But really good also for Lauren, I think, from a professional perspective and the profile of the Director of AHP role, which is obviously a really important role on the board. So well, thanks, Mark.
That's fantastic. Well, again, that.
Yeah. Absolutely. That was all I was going to say.
Thank you, Greg. Or Karen.
Just in terms of the Princess of Wales maternity neonate
Yes.
issue, so obviously there was a huge amount of planning for this before it happened, and I understand that the flows have not quite worked out as we predicted. So I suppose it's some assurance about why that's happened. I mean, these things are unpredictable, I get that, but also about how we're managing that, because I did get a sense that not our neighbours were not necessarily being terribly cooperative.
Yeah.
So I just think it would be good to get some assurance about how that is being managed, because obviously the impact on women in that situation and babies is very significant.
So I think perhaps we underestimated the number of people in Bridgend who would be prepared to travel up to Merthyr. We perhaps thought that perhaps people would not want to make that journey, and it'd be easier for some to go to Swansea or Cardiff. Actually, more people than we thought have chosen to stay within the CTM footprint. Tyrian birth unit here at the Royal Glam has also seen a big increase in, which is good as well, because that hopefully raises the profile of the birthing unit. The call today that Sudan is having with Cardiff and Swansea is also with Welsh Government, and we are seeking to support Welsh Government to help encourage our neighbours to provide support to us. So yeah, that is being managed. Anyway, did you want to?
Yeah, so there are daily CTREP calls, Carolyn, with the 3 sites, with the Director of Midwifery and ops leads. So I think what we're finding, certainly induction of labour rates have increased over the last few years across Wales and the UK, and our colleagues in Cardiff and Swansea are being fairly selective in relation to what they can take because of their pressures anyway. When we did the initial modelling, we thought we would see around 50% of the POW births move up to PCH and the rest to Swansea and Cardiff. We're actually seeing over 70% of the births up in PCH. And so we did, at the very beginning, we did move the POW roster. So 11 midwives went to Swansea Bay, 17 midwives went up to Cardiff. and 9 up to PCH. So yeah, there's been multiple discussions over the line. We're coming to the end of week 4 now, actually. We've got another 7 weeks to go. So there's been discussions all week around maybe Cardiff and Swansea helping us out a little bit more. And as Paul described, there's a meeting happening now as we speak.
Yeah.
But in terms of the safety perspective, both heads of midwifery and Suzanne as director of midwifery are placed up in PCH currently, supporting the teams up there. Specialist midwives have down tools to some extent to support one-to-one care in labour. And as Paul just described, Tyrion has seen almost a 200% increase in births over the last few weeks, which is a good thing because we've been trying to promote that midwifery-led unit a bit, for a long time.
I think it just would be good for us to note our thanks to the staff involved in that, because that's an enormous pressure for people, isn't it? And an enormous disruption and upheaval. So I think we should just know that we appreciate the pressure everyone's under there. Thanks.
Thanks, Colin. Dilys and then Sam.
Yeah. I think that we can take the positives of this as well, because the woman obviously got trust in her.
Yeah,
To deliver their babies and look after them safely.
Yeah.
And I think that goes back to all the work that has been done in maternity over the past 5 years. So I think we need to take the positives. I know it's given us operational difficulties, but at least it shows us that our community trusts us with that.
Yeah, absolutely right. Yeah, absolutely.
I'm just going to say briefly, there's my team are working really closely on this with Suzanne and Carl and others as well. And there's a communication plan for this week to go out to those staff who've kind of been moved out to this, well, to talk about the work that's happening, to demonstrate the necessity of doing what we did as well. But we'll add into that absolutely a thanks for their kind of patience and their cooperation as well, because there have been some disruption.
It's not easy.
No.
Richard, would we ever get to a point, Greg, where we had to refuse to a mother to go to the place that she wanted? If we were completely block in Tyrion and in PCH, and we have to say, look, sorry, but you either got to go to Cardiff or Swansea.
But we do have an escalation process in place, so in Brett status. And in fact, a couple of weeks ago, we got to the highest level of escalation, and some women that had opted to go to PCH on a normal labour pathway were diverted elsewhere. And actually, the conversation was fine, and they were very accepting of the fact. Very, very rarely do we have to divert women away from their choice of place of birth.
Okay. Any other questions or comments? Okay, we'll note the chief executive report. Thank you, Paul. We're going to take a 10-minute or so break. If you can return around 10:25, that'd be very helpful. Thank you very much. You can walk them inside. We'll move on to item 6. Thank you all very much. We've got item 6, our board committee and advisory group highlight reports. Firstly, the People and Culture Committee highlight report from the 7th of August. The report is with us. Before I come to Howell on a separate matter, just want to see, Dennis, anything to add to the report?
Yeah, just two things to pick up, Chair. Under the Assure section, we had story on the lateral moves. The committee were very pleased to see how that was working and knew the positive impact it's having. And indeed, this week on a walk around with Dom, the ward we visited, they mentioned the lateral moves programme, and we're very keen on it. The other thing is in the inform, and I'm sure Howell will have something to add to this about the Welsh Language Standards annual report. It's very good to hear the progress made and some fantastic work going on by the Welsh language team. However, there are some standards which were identified as having low or no assurance, which is concerning, and I'm sure Howell would want to elaborate on that.
Thanks, Dennis. Okay, Howell, I'll come back to you because I know there's just an update in the sense of workforce planning. So.
Yeah, sure. So just a couple of things to pick up. So on Welsh language complaints, I think probably the one to highlight around the standards, which has been an issue for us for a while, is around switchboard. But I know Ben is doing a piece of work with Jill facilities to look at what we can do and what the opportunities are there. Around about sort of 20% of our local population speaks Welsh, and we don't currently have anybody who works in our switchboard who has Welsh language skills. So it's an area of development for us, and one that I know facilities colleagues are working very closely with the Welsh language team on. Just more broadly then, Phyllis has just mentioned the lateral moves process, and in the context of workforce planning, that's been quite successful for us. So for those who may not know, this is a process where at the moment, restricted to nursing, an individual can request a transfer to another department rather than potentially leaving the health board. So that, it might be somebody who's approaching retirement and wants to do something different, or just wants to broaden their skills. They don't have to go through a full application process. It's a much shortened process. And so far, around about 30 nurses have been through that process and have been transferred to other areas. And that's 30 nurses that otherwise have lost. Our nursing turnover has come down from a high post-pandemic of around about the 13% mark. It's now around about the 8% mark. 8% was about the norm for nursing turnover pre-pandemic, so that's really good. But more broadly on workforce planning, we had a really good conversation, really detailed conversation actually at the last People and Culture Committee about workforce planning in its entirety. It's a huge topic area for us. You know that we have significant workforce challenges across all of our professional disciplines, and it drives some of our financial cost as well as having quality implications as well. We are working within a challenging UK and global picture. There's predicted to be around a 10 to 20 million shortfall of individuals in the global healthcare workforce by 2030. So we're operating in that context, but there is an awful lot we can do. Making sure we've got clear plans around data so that we understand the foundations of where we are currently as best we can. And there's lots of work going on there between my team, Sally May's team in finance, and also operational teams, just to ensure we've got a really good understanding of current state. The work I mentioned that we're doing around retention, but also some really good plans we've got around attraction, which would be good to share with IMs at a future point. But we're really developing some good branding materials now so that we can be a bit more prominent in the recruitment market, and also have a reach broader than the Welsh system. But obviously the bit where we need to do the most work is working around our clinical models, our clinical services plan, and obviously the future models of care, so that we can get to grips with some of our challenges. And there are some particular areas of focus around digital development as well, which is in the more strategic end of workforce planning. So we had a really good conversation about that at People and Culture Committee, out of which came a few actions for us. And we'll have a think about how we continue to keep the board apprised of progress on that as the new committee structure embeds in the new year.
Thanks, Howard. That's really helpful. Any questions to Phyllis and Carol on the update report? No. Okay, I'll move on to the Equality and Safety Committee. We've had an update from Carolyn and the team in respect to the meeting on the 23rd of July. There was a meeting on the 18th of September. So, Carolyn, if there's any verbal update on that, please feel free. But any matters to escalate?
Just in terms of the report you've got here, we mentioned the story we had in relation to boarding, which was a very, as it says, very powerful. It was a member of staff who'd been through the system and been boarded. And so there was a huge discussion about that, a lot of learning from it. And I think it has been encouraging to see improvements since then and the learnings taken from that, particularly around risk assessment. Stroke comes up at every meeting, and I think there's a certain amount of frustration that we don't see improvements coming through in the data. We are understanding of the amount of action that's been taken. We know we need a long-term, probably a regional solution, but despite everybody's best efforts, we're not really seeing improvements coming through in that. And just the positive escalation then around TVidyard and HW's acceptance of the action plan, and obviously the huge amount of work that's been done there and the improvements made. But I think those are the key issues.
Thanks, Carolyn.
Paul, just on stroke, Carolyn, and just to reassure you, this is a topic that we are well excited on. In fact, we're going to have a conversation at our exec meeting on Monday about some potential options to try and look at how we can make some improvements, even just internally within CTM. We have been successful in finding a couple of locum stroke consultants to fill some of the vacancies we've currently got, which is helpful, which means the rota is more manageable. But there's also something about how we try and look at how and where the services are delivered and what can we do to try and make it better, even whilst we continue then the regional conversations about what we might want to do on a regional basis around stroke service. Thank you.
Thanks. Any questions to Carolyn on the report? Colleagues happy to. Oh, sorry, Lauren.
Just to say, in terms of TVidyard, great news read there, the closure of their action plan, but they've been shortlisted for an NHS Wales award, which is coming up soon. So it's great news for them. Recognition of the work they've done.
It's an incredible shift, isn't it, from where the service was to where it is now, and congrats on all the stuff. Don,
one thing that came in since the Quality Committee is that the body store recommendations, which we've got in here about our mortuary. We had a meeting with the HTA about a CCTV issue that we've had there. We've now, the verbal report, which we're waiting for the written report, the verbal report has said that we've probably got one of the most robust systems for security that he's ever seen across the UK. So just to assure everyone that there were some issues, but actually we are in a very strong position for all that. So that's really good to hear.
Thank you, John. Much appreciated. Okay, we'll move on to the next item, which is the Mental Health Act Monitoring Committee highlight report. Geraint, any further updates from yourself in respect to the meeting on the 4th of September?
Thank you, Chair. I'll just take the report as read, just to highlight the one matter that we thought needed particular mention with the board was the lack of the electronic record system. But we're aware that this is part of a wider piece of work which is ongoing and will be brought to the board, I think, sometime in the future. That's the only matter that I wanted to particularly mention today.
Thank you, Geraint. Steve.
Yeah, so we just to add to that, then, in terms of the business case that we've been asked to produce from Welsh Government, I'm hopeful that we can get that to the next board. So that's my plan at the moment.
Okay, that's really good to know. Okay, thank you very much indeed. Item 6.2, escalation status update. This is covered in Paul's chief exec's report. So unless there's any other point colleagues wish to raise on our current status, please do so now. Otherwise, I'll move on to 6.3, the board assurance framework. And we've got an update from Gareth. So Gareth, I'll hand over to you this item. Thank you.
Yeah, thanks, Chair. This is a standard report we bring to each meeting in terms of the latest position in respect of our board assurance framework. And just a reminder, obviously, the board assurance framework itself is underpinned by a wider risk management framework. And of course, each individual subcommittee of the board looks at the relevant organisational risk register, risks assigned to those committees as a matter of course at each of those meetings as well. So I'll take the report as read, as others have with their reports, and just draw members' attention to the substantive change which we're reporting this time around, which is around strategic risk number 3, sufficient workforce to deliver the activity and quality ambitions of the organisation, which members will note has reduced in score from 20 to a 16 and the reasons for that are included in the detailed part of the report. In terms of ongoing work to support our board assurance framework, the people team are continuing undertaking a thorough review of strategic risks 6 and 7. Some of that work's been delayed due to resourcing issues, but that we're looking to complete that by the end of this calendar year. And the Executive Director of Finance, Sally May, is also leading on developing a new strategic risk in relation to capital and estates, and that's currently being risk assessed by the Assistant Director of Planning for Capital and Estates. So again, looking to bring an update on that to you at a future board meeting. Didn't want to say anything more at that point, Chair, but obviously all the updates are included in the detailed part of the report and are, as usual, in red text.
Yes, thank you. Patsy.
Yeah, I just wanted to make 2 comments on risk item number 3. It really well explains the change in consequence, so I think that's a really good thing. I don't understand the reduction in the likelihood score, given everything that you've said previously, given staff shortages, just listed in this set of board papers around colonoscopy stroke, although you've said the recruiters and stroke. So I understand the change in consequence, that's really well explained, but I'm not sure I fully understand the reduction in the likelihood, especially given the amount we're spending on agency and bank staff. And my only other comment, and this is a very general comment, this is growing exponentially, it's 72 pages long now, and we need to be careful it just doesn't turn into a fancy risk register, because that's not what it is. So it's just a general comment.
Thanks, Francis.
Yeah, no, definitely to take those comments on board, Patsy, particularly in terms of the last one. We're going to talk around the effectiveness of board management a bit later in the meeting. But certainly what I'd be looking for the board assurance framework going forward is to become a strategic planning tool in terms of how we, populate agendas going forward. So certainly keeping that in mind and not morphing, as you say, into a substitute organisational risk register. On your specific point around organisational, on your specific point around strategic risk number 3, I'll certainly take away your comments on the board in terms of the likelihood of that risk plays in, and just make sure we've got the wording correct around that.
Yeah, sorry, specifically Patsy on that, I can talk mainly about the medical workforce sort of elements as why the risk gets dropped. A lot of it is to do with the way that we have a much different process now that's a lot closer to looking at it on a weekly by week basis as to what's happening. Because we're doing that, we're able to hit things in the bud before they get worse. Now I know, except that we've got our local and ADH spend is high, and we're trying to bring that down along with trying to improve our establishment. But because we set up groups like the performance and escalation group in the medical workforce area, we know where those areas are now. We know where the risks really are. We know what our plans are in case to mitigate against those. So it's because we've got that closer handle on what's happening is allowing us to say, yeah, the risk is still there, but because we're managing it and mitigating it at a much earlier time, we can now reduce the risk of that likelihood of that happening because we're on it. And I think the other reality is that we talked about board development days. We're always going to be in this problem. We are never going to get ourselves out of we've got a perfect number of staff. So that's just the reality of the NHS now, as we've talked about, isn't it? So there is an element of that. We can put it on there and continually have it as one of those high risks, but it's almost a business as usual. Not good enough. We need to work on it, but it's kind of there, which is why we've done the new process we've got with this. And I think it's much the same really with the words in your mouth. It's the same with the nursing side as well. We're much closer to analysing as we go through. So I think that allows us to say we're managing the risk a little. The risk is a little less because we're on it so much more. That would be my argument. But happy to talk about that side here.
Thanks, Tom. Thank you. Patsy, anything else? Yeah. Thank you. Much appreciated. Any other comments or questions to Gareth on the update? Colleagues happy to approve the update of board assurance framework? Yep. Okay. And we'll take those comments back, Patsy, and we'll find. Particularly around the length of the documentation, accepting that, bringing a bit more focus, that would be quite helpful. But thank you for that. We'll move on to item 6.4, the effective management of board business review. As colleagues will know, in January this year, I commissioned a review of the effectiveness of our board business, and that review was to ensure that our board and committee business was managed and delivered in an effective and efficient manner. I'm really conscious of the fact that colleague time is a premium, and ensuring that we are spending time in the right way, providing the sort of scrutiny, the challenge, the support, gaining the assurance that we need to gain as a board, driving our strategy, monitoring our performance, engaging externally beyond our meetings as well with our staff and our services, our patients, and those strategic partners with which we work in both the statutory and third sector. I've been very keen for independent members in particular to use time in other ways, not just in the way in which they engage with the board development sessions and our committees. As a result of this review, we have seen some changes. There have been some changes in how this board conducts its business. There have been changes and improvements to our board development sessions. And what is in front of us now is a proposal to reshape our committee structure as part of that overall review and reform of our board business arrangements. We've gone through a very thorough process. A process has now taken, not far off. By the time we get to a point of hopefully approval and implementation, will be about a year's work of pulling this together. And that's involved a huge amount of consultation with all of you across the board in both the executive and in the independent member teams, discussing where we wanted to get this to in terms of using our resources, using our time more effectively. And firstly, can I thank all of you for engaging in this process? It probably feels to some of you as though it's gone on for quite a while, but I think when you do something thoroughly and carefully, needing to take people with you and explain the rationale and the case for change is really important. So thank you to all of you for engaging in this process. Thank you to Callie, to Gareth, to Emma, the entire governance team who have put in a massive amount of effort in providing a steer to the board as to what this could look like if the board was to change the way in which it operated, and in particular in respect of this item today, the way in which our committees function. What we have in front of us, following the approval of the structure that was given back in March, following the board development session that we had recently, what we have now in front of us is a suite of documentation, which, if the board approves this today, will be the trigger point for making this change to start in January next year. So we will, if the board is happy, we will run our committee cycle as currently planned until the end of the year and start the new committee system in January next year. So what you have in front of you today are a whole variety of schedules and standing orders covering off all of the nuts and bolts, all of the architecture that needs to sit beneath and around our committee structure. This is a huge piece of work, and I really am very grateful to all of those who have made this possible. What I'm asking you to do today, obviously, to consider this proposal. If there are any particular questions now at this point, we'll be grateful to colleagues if you have any to raise. Any further comments that you've not had the chance to feed in thus far. Before I move on, any particular questions or comments on what's in front of you? There are quite a few documents in front of you that Callie and the team have spent a lot of time pulling together. All of this, of course, was online for colleagues to review as we've gone through the process. I know that some of you have contributed to that in terms of those observations. So what we have with us now, I think, is what feels to me is the settled article. I said at the time, when we considered this back in March, that we would review the new system as we go through the first 12 months. And there may well be changes to this at the end of next year. We may want to tweak what we have. We may want to alter the membership of our committees. I'm conscious that we've had new board members join us within the last 12 months. There will be other new board members who will join us within the next 12 months. So it may well be the case that we want to flex this at the end of it, which I think is a really healthy thing to do, to evaluate, to review, and to change where needed. So any particular comments now on what we have in front of us, or any questions as to the process? You've had the schedule, of course, of the meetings for next year. So we've already started planning those well in advance. And we've had the memberships pulled together as well. So over to you. Patsy.
I just want to say I think this is really positive. I read and sort of paused over some of the terms of reference, and as I was thinking about it, I thought, oh, my initial reaction was, oh, I'm not sure that makes sense. But then thinking and looking at more closely, they do make sense. And I just wanted to say I think it's really positive. I was on holiday on the 11th of September, so I wasn't part of the session you'll have had there. So this is the first time I've seen this whole suite. Yeah, and I think it's really positive.
Thank you, Patsy. Helen.
Just to say, completely support this. Think it's a really good piece of work, and thanks to everyone who was involved in it. And completely support it. Yeah.
Can I say, one of the exciting shifts in here is about that provision of a strategic strategic delivery committee, and then the operational committee as well, getting people to focus in two very different ways, but having the flexibility to look at many different things that sit within that strategic realm, and lots of things that sit in the operational side of it. It is quite a shift for us as an organisation. The public sector is usually uncomfortable with stepping things down. Usually we're very good at stepping things up. We're very good at creating committees, task and finish groups, advisory groups. It does give people a huge degree of comfort. But what we've done with this, I think, by streamlining our arrangements, it allows people to focus their time, their energy. And I was very aware that, you know, when it came to the involvement of the executive team, we had executive reports that were going to more than one committee, and they were just being perhaps tweaked. So this around all of us using that time far more effectively. And our visibility as a board is really fundamentally important. I said that at the time when I was appointed, that whilst we are, for those of us who are independent members, publicly appointed by the minister, I think board visibility for all of us, with our staff, with our patients, getting out and seeing our services, looking at what we do and how well we do it, is a really important part of our board work, and providing a bit more time to do that, as well as spending what is a lot of time in our board and committee environment, I think was really important. So, but thank you to all of you for your support, and that commitment to review is there. It's a very strong one, and we'll all be looking at it and engaging with it and making notes as we go through the year and saying, well, perhaps we can do that a bit differently. But fundamentally, I think where we've got to, I think is fantastic.
Well, yeah, I mean, just back to your point there about strategy, I think, if you think about the challenge we have in the organisation, isn't it? It's constantly juggling the here and now and the immediacy of what's in front of us, with also making sure we've got enough time to talk about the big ticket things, which we know are going to be the solution to some of the operational realities that we're dealing with today. And I think for us, it's once the structure's now in place, it's going to then be about how we make sure that sort of key strategic programmes of work are being sort of fed in through that mechanism, and that we can highlight, because I think, there's lots of discussions at the moment, as you say, John, nationally in the UK and in Wales about longer term plans for the NHS, but we need to have a structure, therefore, that has the local opportunity and place and time to be able to talk about the longer term stuff, and our ambitions around improving population health outcomes, improving integration of primary and secondary care, the work with Matt's going to talk to us about social care. There's a lot of big ticket strategic topics that we have to have the time to talk about, as much as we do talking about some of the operational challenges and pressure that we're also dealing with today. So I think this is a really good point. And I think, as your point there about reviewing, that's a really important part of any of these sort of changes. In 6 months' time, how's it going? Does it need some tweaking? Does it need some adjusting? Are we making sure that all the topics that we want to be included in those agendas and we're going to have to be quite rigorous, I think, as ourselves about, not just putting stuff on agendas just because we think everybody needs to know about it. It's about, well, what's the purpose of bringing it into that committee to make sure that it's actually about having a public discussion, because there is so much stuff that could be highlighted in any of these committees. There's so much going on a daily basis. The risk is we don't want to overwhelm. And so I think an effective, ongoing review is really important.
Yeah, and I think it's about that shared responsibility as well, because by working through what we've worked through the last X number of months, this has been about ensuring that colleagues who are sitting on these committees are helping to drive the agenda. So if there are really important matters that aren't on the agenda, then if they're not on there, it's because we've not asked them to be on there. So, independent members and exec colleagues very much in the driving seat here to ensure that the right things are captured and that we are focused on those things that are the most important. So you know, I think, and I don't know whether any of the health board in Wales has gone through this process, but I think it's been a really healthy thing for us to do. But of course, as I said earlier, in the context of us making changes to how we operate in our board meetings and how our board development sessions have also been delivered. So this has been a board-wide review of the effectiveness of our arrangements, not just focused on one bit, but looking at the system in totality. Helen.
To pick up on something that Paul said about strategy and committees, I accept all of that, Paul. And as I said, I completely support this. I think as an independent member, sometimes it's useful to get information through other means, things that you know that are coming up. I found some notes that we've had from Greg really helpful recently, so they're useful, I think, to keep us as independent members on the board. So
I agree.
We're interacting with people.
Yeah.
We we don't say, oh, we didn't know those inquests coming up, or we didn't know.
So I think
that's
I
really
think that's, and it's also things like how we use the briefing sessions
Yes,
for
I agree.
on hot topics that are happening at the moment, or things that are going on, or briefing notes that get sent around to people just so you're aware. So sorry, I wasn't saying that.
No, I know you weren't, but I think it's helpful to just remember that
there
those
are
other
other
things are
mechanisms as
really
well.
useful.
Yeah.
Thank you.
Any other questions or comments?
Just a comment or a request, and I wasn't at the session either on the 11th of September, unfortunately, and so this may have been covered there, but when we talk about a review at the 6 month point or and on, so I guess for me it would be okay, so what would good look like, what would change look like, because otherwise what are we going to review? And this may have been covered, so the changes we put in place, and I agree with Helen, I think this is fantastic work. But I guess what are we actually aiming for? What does it really look and feel like, as opposed to we change the system and that in itself is enough? So that's all I would say is, if we were doing some sort of survey with the board, what are the kinds of things you would expect to see and the changes that would be put in place?
Thanks, Rich. We'll take that back and have a further conversation about how we set some metrics on which we're evaluating how we do
Nothing
that.
complicated, don't spend any more time.
But also, as committee members, of course, as you go through the process, you'll be going, actually, I'm not sure that meeting worked that well today, and you'll know the reasons for that. And I think it's about having feedback, making sure we have feedback throughout the year as well, so that we can capture what works, capture what could be tweaked. So it's not just a huge piece of work at the end of the year, but we are reflecting as we go through it. And there's some changes we can make, perhaps particularly in how the committees work in terms of the agenda setting, timing, papers. Those things can reflect as we go through the year. We don't have to do it right at the end.
It could even be something simple as noting things are not being duplicated in the way that we've mentioned.
Absolutely.
Things have been duplicated. Something goes to one place and it doesn't go to 4 places. For consideration. It doesn't have to be difficult to do so.
Gareth.
I definitely accept that challenge, which is something we look at. And also, just to go back to the original driver for this, we did set out some objectives. So actually going back to the first principles, why we introduced this in the first place, and is it doing what we hoped it would do? But I think, as John says, any real-time feedback we can get as well, we really appreciate it.
Good. Okay, thanks. So look, having considered the proposal in front of you, at 5.2 of my report, the board's being asked to approve the amendments to standing orders, the terms of reference, the schedules to standing orders for the 7 committees. There's a copy of the board assurance framework report with the strategic risks assigned to the new committee structure and the variation to the standing orders in terms of the publication of papers. So firstly, can I ask colleagues to indicate either their approval or their disapproval of those who approve? Anybody disapproving? Okay, thank you very much. Can I also ask the board to note the following activity in the next section as well? So just to say that having approved this, everything will be updated in line for the 1st of January 2025, and those committees that are currently operating in the current arrangement will continue until the end of the calendar year. And there's a list of activities there that the team will take forward as a result of today's approval. Thank you all very much indeed. That's a significant shift and a very big change in how we work as a board. So thank you very much indeed. We'll move on to Matt. Fantastic. Good to see you again. A very warm welcome to. Yes, consider Matt. Matt, as you know, is our regional director for integration, and Matt has been doing a huge amount of work on behalf of the Health Board and the 3 local authorities in developing our integrated care pathways, and that has resulted in a variety of discussions about how we as statutory bodies can be better at integrating those sort of community care-based services that we provide, and what potentially the future could look like. I know we're ambitious to do more together, but it's about making sure we put things in place in order to support and deliver that. So I thought it would be useful for Matt to provide an update to the board. This is part of other board activity that the board will be aware of, particularly around supporting people to leave hospital to get home far more quickly. And the board will also be aware we're doing a piece of work around what the shape of our primary and community care could look like from next year. So lots of work going on at the moment, and this is a really critical part of that. So Matt, I shall hand over to you.
Thank you, Chair. Good morning, everyone. Really grateful for your time this morning. I thought I would cover 3 areas really briefly. First of all, a reminder, I suppose, about the purpose and shape of this work on an integrated community care system for our people and people living with frailty. Secondly, to tell you a little bit about the progress over the last 6 months. The Chair indicates some of that time goes quickly, doesn't it, when you're having fun? And it's 6 months, almost exactly, I think, since I presented to you the last time around. And then thirdly, to refer to this important work on developing a binding partnership agreement across our statutory organisations. Really, I'm previewing some of that with you. That needs to come to you more formally for consideration and decision making through the autumn and winter, but hopefully useful for you to see the outline of that today. So, this picture, if you like, of a target model for an integrated community care system. So we're thinking here of older people and people living with frailty, and of course for that population group, it's the way that their health and social circumstances interact and compound that makes supporting them really, really challenging for statutory organisations. As I said last time, I think continuity and coordination of care becomes really, really important, and that's challenging in a world where organisations might be inclined to act and plan and do separately. So absolutely essential that we come together, and not just as local authorities and the health board, but as the wider health and care economy, including the third sector, of course, housing associations, many others with us on this journey. So appreciating you might have seen the outline of this last time, but newer to members who joined the board quite recently, if I just describe that quickly from the inside out, if you like. At the heart of this is the development of new integrated community pathways. So on the one hand, a reactive, urgent community response. So the idea there that where we can mobilise quickly to avoid an admission, perhaps through the mobilisation of community services, that's going to be in the better interests of individuals. A proactive pathway, population health management, working closely with Philip, using and combining all those resources that we have in the community and looking at local authorities is a particularly important part of that. Navigation, essential here. Our clinical navigation hub, of course, is developing all the time and showing some great results. That as the route in perhaps to the urgent pathway, thinking about how we align that with local authority navigation at the same time. So those community pathways are at the heart of this. We want to deliver that support increasingly through integrated teams on a locality, often a cluster footprint. And we think those can best be managed through more of a unitary arrangement. We have that in place in some parts of the region. In Bridgend, we're exploring the merits of that model in other areas. If we want to do that, we need some hard wiring behind the scenes. We need to reach for some legal frameworks to help us to do that. And I'll describe that in a little bit of detail in the final third of the presentation. So a memorandum of understanding and a Section 33 agreement under the NHS Act 2006, potentially. And that all then supported by some of this infrastructure that we have at a regional level, a new demand and capacity tool around intermediate care potentially, market stability reporting, very critical here, moving really to aligned and integrated commissioning. I'll say more about that in a moment. And absolutely essential then as a regional partnership, we're working towards the same outcomes, we've got the same objectives, we're driving in the same direction, so we can hold each other to account on a kind of quantifiable basis. So think of that as a target model. We've got activity in all those areas, as perhaps Tara, if we can flip to the next slide, we'll be able to start to demonstrate that. So progress over the last 6 months then, I think, I hope certainly momentum is building. A key area of work in the urgent community response pathway, as the chair indicates, is commencing this work on new integrated hospital discharge teams. So why is the community important in that? Because it's primarily a presentation about the community. Well, it's that community pull model that we're trying to get rather than hospital push at the moment. So really working hard. We've got different models, discharge models in place across our DGH sites. We've got some great inheritance to build on. Stay well at home, of course, has been recognised as a leading model. Time's moving on a bit and we need to realign that. So we've had Task and Finish Group stood up on that quite recently. We're looking to implement a new model second week of December, ahead of the really intense winter pressures. That's a real stretch target. We've got a ton of work to do to get to that, but we're working energetically towards that. There's progress on other elements of the urgent response pathway, and there are big implications here for the way that we use regional integration funding, that discretionary funding that we have to support this. Interesting work with local authorities and the clinical navigation hub. We've had some shadowing of social workers into the navigation hub. So thinking where there's clinical support, but we need to put in carers there really urgently to enable the clinical support to move on to the next challenge, so that individual can be supported in their own home. So just starting there, thinking about in the long run, local authority single points of access, the navigation hub, is there a strategic agenda there? A developing dialogue about ahead of the hardwiring being sorted out. Can we just simply work better together on a local footprint basis? I'm encouraging conversations with RCT there at the moment. This endorsement at a regional level of the partnership model that I've described. We've won some support as well. We did well in a competition that the Health Foundation ran for their improvement network, their Q network that you might be aware of. So some practical support and a small cash gift as well, which we'd like to put towards in part the development of a demand and capacity model. So we really need that, don't we? If we want to commission in an integrated way, we need a shared evidence base for that. That's a challenging piece of work, but we've got some support at a UK level to help us to do that. And again, as the chair says, really important, the cogs need to turn together here. So be it the 6 Goals programme, be it primary community care, the reorganisation there, all this needs to work synergistically rather than the risk of grinding against each other. So I and senior colleagues working really closely on that. Tyler, the next slide, please. And it's really difficult. You said this last time, how challenging this work is. There aren't many precedents in the UK for areas where this is all sorted. And this analogy, if you like, from Jim Collins, I don't know if you've come across his work, but where he looked at successful organisations that endured over the long run, he found that it wasn't some miracle moment. You know, it wasn't a flick of a switch. This is really hard, and there's a number of things to come together. This analogy of a flywheel that at first turns really slowly, but as you can start to build momentum, you go from 2 to 4 to 6 to 8 to 16 to 32, and the rest of hopefully that wheel is starting to turn for us. And this funny little picture on the right hand side, you know, maybe the stars are aligning. So that's a model of Richard Trevithick's steam engine that rolled down the track from Derry Steelworks through Abercynon over 200 years ago that changed the face of our community. So maybe we can take some inspiration, Chair, from that innovation.
It's going downhill.
I was worried about any resemblance to the gentleman at the back of the train there, but hopefully not. So, you know, this is challenging, but hopefully momentum is building. Tyler, please, the next slide. So a little bit more in practical terms then. I'm aware there are a lot of words there and looking at the back hard to reach, but just to give a sense of where we might be and where we're trying to get to with this. So organisational centric commissioning. I don't think we're at the far left-hand side of this diagram. You know, I think there are some great examples of where we have integrated services, we work together across the organisations, but there's certainly more distance to be travelled along to the right-hand side of this diagram, where we're really at least aligned, where we share intelligence. We're fishing in the same provider pools a lot of the time, aren't we? Certainly in terms of home care and the residential market, and big decisions being made in Geraint Authority and others at the moment right now about that. So it's so important that we're able to work together on that, and ultimately potentially to move to a much more integrated model where we're pooling not only our thinking and decision making, but the resources that we have to bear, and certainly the way the teams operate on the line. So that shift across the right of that diagram is one of the benefits that we must achieve through this work. Next slide, please, Tyler. So some of the wiring then that we need to developed behind the scenes. We had a discussion in the regional partnership boards quite recently about this, really prompted by Jonathan and Paul and their counterparts earlier in the year in the local authority organisations, really wanting to enhance the level of partnership working. So in the first place, the idea there was to develop a memorandum of understanding between our organisations. A lot's gone through the regional partnership board on this, but whether everything's come to the statutory organisations decision-making table. So the purpose of a memorandum of understanding, which we put to through the autumn, is to be really clear on what each organisation is seeking from partnership with each other, and to start to develop the outline for a Section 33 mechanism. Why is that legal agreement important? You need something like a Section 33 agreement that gives the ability for organisations to act on each other's behalf, really to operate the functions of the other organisations, whilst the statutory responsibilities are still retained. That doesn't cut across the accountability for delivery, but that enables us to do practical things like appoint two integrated hosts. For example, we got that in Bridgend because there's a Section 33 agreement. I think we'd like to do it in other areas. I want to emphasise a staged approach to this. This isn't, it just happens in one moment next spring, but we want to get to kind of first base next spring. We want to have in place regular review points to increase the depth and sophistication and impact and effectiveness, I think, of that model as we go forward. And doubtless there are significant staff and wider stakeholder communication work that we need to do as we go through this. That is very small, isn't it? From the back of the room, an eye test and a presentation. I'm sorry. Yeah. I can just do this here. So a little bit of detail, and as I said, this is previewing then. So what are we trying to do here? So I think as a minimum by next spring, we're looking to develop a regional Section 33 agreement to get that collective ownership of the vision and some of the operational priorities that are really important right now. I think the scope of it will be the community pathway model that I described at the outset. So the services in more detail will sit behind those descriptions of urgent response and population health management. That would seem to fall quite naturally from it. We should start to provide the basis, those aligned commissioning intentions, moving towards more of an integrated arrangement and starting to work out how we do that. I think there would need to be some adjustments to regional governance that come with this. We would need an operational board, I think, to oversee that Section 33 agreement as it comes into play. Critical link here with the joint partnership board. So in each local area, they're already established. In Bridgend, the joint partnership board is the authority that oversees their agreement there. So the work on accelerated cluster development is absolutely central to this. And I think this is where it gets really interesting in governance terms, that we know we can use resources better in our system. We know that allocative efficiency, if you like, it isn't optimized right now. So this arrangement is a basis for really thinking about that. Can we shift resources in an integrated health and social care system? But that comes with challenges, doesn't it? We've tried to pool resources around care homes before, and there are understandable concerns about sovereignty. My belief is there's absolutely a way through that. I think in the first place, we should have more clarity, more transparency about the resources that are in play. So that idea of a notional pool fund, where there's a bit more open book, I suppose, where we are on our investment decisions, would be a natural starting point for that, with the aspiration that we would move towards more of a risk sharing basis in the future. So think of some of that as a kind of heads of terms to this agreement. The detail about the individual services, that's set out in schedules to the agreement. So as different parts of those pathways that I started to describe come on, if you online, if you like, we can add those to the heads of terms agreement. So we get some shelf life, we get some continuity in terms of purpose, aims and objectives, but we got some flexibility in the way then as our services adapt, we can bring those into the scope of the agreement. So our starting point next spring, I think, needs to provide a bit of continuity on the one hand, where there are legal agreements in place that would be folded into this regional agreement, but also then the timetable for the development inclusion of other services here, how we'll redirect regional funding and a timetable for further work on that, and also for looking at some of those management arrangements that we'll have in play. So that's roughly the outline. I'd emphasise the stage approach. I think in primary community care, a lot of reorganisation done recently. We don't want to cut across that. We don't want to upset arrangements, but there's a logic to the way this would unfold. And just the final slide, Dan. please, Tyler. So I think my conclusion would be momentum's building, trying to balance ambition with pragmatism. It's lovely to be all blue skies about this, but we need to deliver in the short term as well, which is why the work on integrated discharge is a massive focus of mine right now. And there's another version of this, I think, which is all about people and confidence and trust. I think that's massive here. The best technical agreements in the world, and that counts throughout if you've not got a positive enabling culture to provide that. So I just wanted to say that hasn't gone without. And tomorrow morning we're spending some time as senior executives together, hopefully really working on that stronger professional working relationships amongst ourselves as a starting point for that. So thank you for the opportunity to present that. I'm delighted to hear feedback, certainly, and take any questions.
Thank you, Matt. That was really helpful. Okay, any points or questions to, or do you want to this point or?
Yeah, so I mean, this is really, really exciting, I think, and really important step forward. And I think just, I guess a couple of bits Matt alluded to. I think it's really important to say this is not trying to ride across the RPB. This is about the statutory organisations in the RPB trying to work out how we exercise our statutory functions in a different way, because the RPB is obviously broader than just local authority and health board. There's a lot of other players in the RPB that we still need to have an active integrated arrangement with. So I think it's just really important to remind them that this is not about trying to sort of, ride across that. I think the thing I'm thinking, Matt, that this is a lot, obviously, as you said, the hard wiring that's required to make these sorts of arrangements work effectively. But I think there's something also about how we tell the story about why this is needed for the individual citizen and patient, because I think, fundamentally, candidly, most of our citizens assume that we have this level of integration already, and that we're talking to each other about all these things and we're sharing things, and it's only the people working in service appreciate sometimes the different sort of barriers that exist. So there's something about how we, as well as all the sort of internal governance agenda and conversations, that we sort of use some of the stories I know we've got plenty of around people where it's worked really well, but also people where perhaps the system didn't work as well as it could have done for them, and the opportunities if we can try and join things up a bit more. And I think ultimately, we can't deny the fact we're all in local authorities and health board environments that are really challenged at the moment, both in terms of resources, money, staff, pressure on demand. The only answer to those challenges is to work in a more joined up way across our statutory organisations. In fact, if anything, even more so in those circumstances. And I guess this is an opportunity for us to avoid the temptation that often exists when pressure builds, that everyone reverts to inward and puts the fences up and says, well, we can only focus on what we're dealing with at the moment. Actually, more than anything, we've got to be much more out there. And that's going to challenge us as well as the health board, because we've got to be as equally as worried about how many people are sat in the community waiting for a home care package and the number of people going into long-term residential care, as much as local authority colleagues have got to be worrying about how many ambulances are queuing or how many delayed transfers are happening. So there's something for me as well about what's the performance framework that sits around this governance structure, so that we become more mutually accountable for each other's challenges, because ultimately this is all about everyone taking a collective responsibility for how we make a system work more effectively, because actually our patients and citizens need it, and our staff want that as well, because they get equally frustrated. And my final point is, and this is Stu's, I know, done a lot of work, underpinning it also from a governance perspective, we need shared information and data about the individual, because at the moment people are still bouncing between different bits of the system, health and social care, with different records, different information, people not always being aware of what's happened yesterday with that person, with somebody else dealt with. So as well as the governance and the technical governance and financial governance, we also need to think about sort of information sharing and data governance and sits underneath this. But really, really positive, and really looking forward to how we build this work further.
Any questions to Matt on the update on where we're potentially headed to? Patsy.
Yeah, I mean, echo everything Paul said. This is so welcome, and it is the only way forward. But what often happens with Section 33 agreements is things fall down when you come to accounting for money, because organisations are statutory organisations in their own right. So whilst you can put the money in and spend it together, there's always a bit of a debate about, well, who spent that bit and who spent that bit. And so what can we do? How can we help, and what can you do to prevent that ultimate barrier to this succeeding?
Yeah, it's a critical question, isn't it? I don't think there's a pat answer to that. We've got some examples of them where we've made a little progress, I think, to the west of the region there, and we know where it's been really difficult previously. We need to learn the lessons from all of that. I think the Paul's point about the accountability framework and being there by results and having the clarity there rather than following the input so much, I think is a big part of it. We need to have that kind of results-based framework that goes with it, that will give confidence then to councillors, the board members, increasing transparency around this rather than reducing it. I think needs to be an absolute guarantee for elected members, for board members to provide that confidence. But it's you're dead right. That's the tripwire often where this kind of Rachel?
Yeah. Matt, you'll be familiar with the third sector code of practice and funding. Well, it's not new, it's been around since 2014, but I don't think it's ever really been applied particularly well. WCVA are doing a big piece of work with Welsh Government third sector team there to rejuvenate the new code, and it will have implications. It will, I think there's a fair amount of expectation on statutory commissioners and commissioners generally, so grant funders, but from a statutory point of view, the code of practice does place a lot of emphasis on engagement with, as a commissioner, with the services that you're going to buy. And I guess, because I've complained to you about this plenty of times before, that very often individual commissioning practice across any area of non-statutory services is the weakest link in all of this. So, what I'm asking is, how do we ensure that whilst the agreement might be between the statutory partners, that other providers are not left out in the cold until the last minute, and then we have a situation where with their kind of contribution to this whole system, because the whole system is far bigger than health and social care. How do we make sure that they are involved in those conversations, I guess, right the way throughout, and talking about this is what integration really looks like, not just health and social care. And that code of practice for third sector funding will be built into Welsh Government expectations. So, if the RPB is saying this is our plan, they will be asked, how does all of this comply with third sector code of practice? So it's going to be a new and welcome actually expectation and requirement. I'm just wondering where you're sitting with all of this.
Really important. So much of our provision in the community is underpinned by Regional Integration Fund right now, and I think we've struggled in searching for a sustainable model. We've kind of hedged our bets in the way that the third sector, we've got annualised approaches. I hope with this we can have a good degree more of continuity with it. And your analysis, I think, is spot on, Rachel. And we need to move from organisational centric commissioning, where individuals are taking decisions and cited on others' actions, when in fact we're dealing with the same group of organisations. So working together, I think, to build that, what would a regional commissioning approach look like then would be critical, and make it, and care home providers, independent providers would say exactly the same. I'm sure they'd have the analysis. So this needs to deal with that. Get around to that in Linda.
I know, I was going to say what you just said. So. I don't know what I meant.
Inspiration. The issue has always been the distinction of statutory functions and territorialism, and trying to. The important thing is that for the citizen who is the receiving end of this, that it's essential for their experience that all these different partners with these distinct objectives, distinct accountability lines, distinct statutory functions work better together. Rachel and I were fledglings on the RPB many years ago, and it's great to see the maturity which has come, and the way that the RPB and the different partnerships have matured is very welcome. This is superb work. I'm really pleased to see it. You mentioned about flicking the switch to make it work. I think the frustration is we flicked quite a lot of switches over the years, really, and it's finding that hopefully enough switches are now being flicked that this is starting to develop into something that we could see that would become a settlement, an established part of working that would deliver a long-term benefit to citizens. Maybe the imperative has come as things have become more challenging, both financial and in terms of demand, and of course all the other resource issues that we all face with recruitment and retention of staff, the training of staff, all of these things we have to work at together. I'm delighted to see this. I just hope it is that forms part of anyway that long term. One of the other issues. One question I had, which is where, I mean, the Welsh government were very keen on sort of holding threats of forcing pooling of funding, and where are we in terms of pooled funds, I suppose, and also how do we explain all this? This is terribly wordy, and I've seen it all, and we've all seen all these words before. How are we going to explain it to our resident? What can we explain? How can we describe this in very simple terms? We want to prevent as much as possible people coming to hospital. When you have to come, we want to try and make your stay as comfortable and as short as possible. And hopefully we're going to find you very quickly a way of getting back to your own home in a safe and caring way. And how do we describe that to the public?
Thanks, Karen. Well, I think how we describe it is coming back to the individual stories about patients and citizens, isn't it? Because actually it's about saying, how do we as statutory organisations work more effectively to ensure that you can achieve the things you want to achieve, which largely tends to be people living better lives, healthier lives, staying at home for as long as possible, supporting their carers and their loved ones who are looking after them better in their own homes. And certainly my experience of doing these programs work elsewhere is if you root it back into the story about the individual,
yes,
not only for the patients and the citizens do they relate to that, but the staff also relate, because the staff won't be worried about all the technical arrangements that sit behind this stuff. They'll just want to say, how do I do my job better, and how can I make sure that I can share information more effectively with my colleague down the corridor or in the same room who's of a different profession to me. So I think what we need to try and do as we start to get more into this and start to socialise it more with our population is being able to sort of tell the stories, because, you know, most people's frustration with the health and social care system is things like, you know, don't know where to go, have to tell my story any number of times over, all over again, every time I meet a new professional, people don't seem to talk to each other or share the information, can't get the service when I need it, it's not time, all those things. We'll do the engagement, but I can tell you now what the answers will be, because every place I've ever worked, it's the same themes that come out. So our challenge is, how do we turn that around and say, these are the things we know are frustrations for you, and this is what we see this structural change behind the scenes doing to improve that for you face to face. So I think that's a really important part. Your first point, Garen, about the pool budget, I think there's a big conversation going on. I know the current First Minister, when she was Cabinet Secretary of Health and Social Care, was really keen to look at new and more enhancements around how health and social care could be more effectively. I would largely imagine that both the new Cabinet Secretary and the Minister for Social Care, who we've met, John and I have met with Matt to talk her through some of this work. She was very supportive of it. She happens to be an MS in our patch, which is also quite helpful as well. So I think there's a real opportunity for us to potentially, when obviously Matt, having worked in Welsh Government for many years in this space, is sort of and come into it from the other side of the fence. But I don't know, Matt, what you think from the appetite politically? I think there is a real appetite.
I think this is the agenda, you know, the development of integrated community approaches is where policy is currently. So we're heading to an open goal in policy. They're really attracted by the way we describe the model. There's a citizen-facing presentation of this, absolutely. But for the more technocratic minds in government, this kind of makes it they're really behind us. There's encouragement consistently to push forward and be an exemplar, I think, to other parts of Wales. And the assurance on the regional partnership board. Really, it's through the regional partnership board that the model's been developed, and that was the first port of call, really, to have that endorsement, so collective endorsement, not so much statutory organisation, but and then third sector signing up to this, but as a group, this is the direction of travel that we want together, and that was the approval that we got just last month in August. We're in a good place there, but yeah, an absolute ton of work to do for sure, but yeah, we're in a good place at the moment.
Right, just two very quick points from me. The first is about the changing nature of people's needs. In the last, I'd say, 20 years or so, we've seen a shift in the sorts of health and care needs that people have. And for those being met, invariably you have people needing services and support from a variety of different organisations, not just health, not just social care, but third sector, community-based organisations, things that keep people well and safe for longer, closer to where they live. And you can't underestimate how things have changed in that time period, where it means we have to be far more flexible and innovative in how we engage with people, how we create the sort of working environment for our services with others to better deliver for people's needs. And I think it just demonstrates the fact that things are very different now to many years ago in what people expect and what people need. Second point is around your experience thus far in leading this really important piece of work, because Section 33 is within the Social Services and Wellbeing Wales Act that was passed 10 years ago. I don't know whether other regions of Wales have used Section 33 to deliver an integrated approach in the way that the Act was set out and the way the expectations were laid out by government at the time. So I suppose my just an observation, Matt, is as we get into next year, as we get into April, hopefully with agreements in place, I mean, we start in April with using Section 33, that perhaps you might want to reflect some of your experiences back to government about how this has gone, what's made the difference, what really helped partners to come to this point, what were the sticking points, what were the opportune points, because it does concern me. We've had the legislation in place for 10 years, yet the public sector has struggled, I think, to really make good use of this. I know there are one or two other examples, but I think we're probably at the moment, unless I'm wrong, I think we're the only health board region at the moment that's actively considering and pushing this agenda forward. So I think there's a learning point there for us as a system, and perhaps something to reflect back to colleagues in Welsh Government about how well this has gone.
Yeah, very much important question, Jonathan. Changing needs, I think the multidisciplinary integrated teams on a cluster footprint, that's the code, that's the jargon. What that means is our teams just working more closely together, having that increased level of professional contact. I've been surprised that isn't strong and vivid currently. So there are things that we can do to just make this work, and better. The reflections back at a national level, I think we're in the lead in terms of the vision here. There've been other attempts previously along these lines. Colleagues might remember Gwen Frailty back in the day, which was, very high profile. I'm trying to find out a little bit more in truth where the systems are, but we're ahead of most, I think, in terms of the level of ambition. The thing I noticed coming into the role was absolute unanimity in terms of we want to do this. It wasn't a matter of persuading. Easy to say this morning in this company, I know, but it wasn't a matter of trying to persuade at the top table. This would be a really good idea. Can't we do it? It was absolutely, we're going there. So let's work on the how and go with that. And I was, pleased to find that, because without that, before you would start, you're in trouble, aren't you? It's an important characteristic, and it's still quite early. I would say, everything's difficult with there's a level of challenge, but I think we've got a plan. I think we know where we need to work now, that clarity of vision. So let's see how fast we can go with that.
Fantastic.
Can I just make a final point on reflections? For those of us that have been in the RPD space, well, I joined in 2017, and I think Eric was already there then. It feels as if, the regional partnership, or certainly in this area, we were kind of finding our way for quite some time, as all regional partnership boards would have been, and very much led by what Welsh Government said we should or shouldn't do, and we were kind of, all in with the Act. And and we were all at sea for a little while, I think, because everything had to happen so quickly and getting, you know, if you.
I don't think we did anything except review governance for about 3 years.
Yes, that's exactly. I didn't want to. Yes, that's exactly what happened. And then I guess COVID came and threw everything a little bit up in the air. But, you know, this feels like as if we've kind of come to a conclusion. This is how we want to operate. And it gives us the resilience to be able to cope with changes in senior personnel, changes in political, you know, flavours, you know, what anything that can come along and upset that balance. This is our plan, and we know what it is we want to do. And I think that's in itself is so important for us because it can be resilient, you know, when all of those other things happen on the outside. So yeah, great.
Thank you, Richard. Okay, thank you all very much. Matt, thank you for the update and the presentation, and I'm sure we'll return to this fairly soon when you'll come back with a proposal to the board for formally that discussion and decision around the use of section 33 and other areas of our work as well. So Matt, thank you very much indeed. We have to take a slight break now. If colleagues can return at 11:45, that would be very helpful. Thank you very much. Ladies and gentlemen, we'll reconvene. Thank you very much indeed. We'll move on to item 7, delivering our plans. Colleagues have got the information in front of them for the integrated performance dashboard. We'll deal with the section first, and then after that, obviously, we'll come to Mark for the performance bit. Can I welcome Sarah James, our Deputy Chief Operating Officer, who's joining us by Teams for this item. Sarah, thanks for being able to join us this morning. Certainly appreciate a number of things you're having to deal with this morning, so thank you for being able to join the board.
Thank you.
What I would do, Sarah, am I going to come up to you first? It's Linda's going to introduce it, and I'll come on to Sarah afterwards. Linda, I'll come to you first. Thank you.
Yeah, thanks. Thanks, Chair. So just very briefly, my sort of normal little update on any changes to the report. We've added at the beginning of this now the accountability conditions that we talked about in Paul's report. Now, a note that we haven't had time. We've listed them there, but note that we haven't had time to give any indication of our direction of travel or confidence in achieving them. But rest assured, we'll work on getting you that the next time. So that will be the sort of next development of the report. But yeah, so Sarah, actually, which ones come up first? It's some of the public health ones come up. Just trying to think which order we normally go in.
No, I think we're going to come to Sarah first.
Yeah. Sorry, Sarah. So any things that you want to pull out in terms of the performance report from your ops perspective, please?
Yes, thank you. So firstly, I think just to extract a couple of the positives out of the month's report. Certainly from a CAMHS and mental health perspective, we continue to meet the requirements of targeted intervention for CAMHS and mental health. It's performing really strongly against all domains, which is really positive. The teams continue to focus on improving access to psychological therapies, and obviously we're about to recruit into the substantive mental health director position. So all good there. Urgent care, significant improvement to note for August in terms of 1 hour, 4 hour and 12 hour breaches with 100% red release compliance. This, I think, has been a direct response to the activities undertaken during the reset fortnight, which we initiated on the 12th of August. You may recall from papers that have been circulated, we focused on a couple of areas, in particular performance and the domains that I just described, but also the initiation of the stamp project, which I have to say has been quite groundbreaking in the way that we manage acute medicine flow at PCH Hospital. So in essence, what we've seen is activity tripling throughout AMU. We've seen a doubling of activity going through medical SDEC. We've been able to close some of our surge areas, so that's Ward 7 at Royal Glam and the GPAU corridor at PCH. We are in the process of analysing the data, so the performance indicators are looking really positive. We're also triangulating that with the quality indicators, falls, pressure damage, IPC, patient experience. But so far, I have to say that all that's looking really impressive. What we've seen is a significant reduction of delays across PCH. And I think it's fair to say that we are seeing a sustainable change there. So it's not just a consequence of the 2 weeks and then back to business as usual. We are really seeing some sustained improvement. So that's really encouraging. So in terms of that, what's next? With winter rapidly approaching, I plan to run a series of reset events, which will take us up to March. And through that, we will continue to focus heavily on performance, but also rolling out the stamp project across the Royal Glam and Princess of Wales sites. So we are in the process of putting up together a plan, which we'll be able to talk through a little bit more as we progress. In terms of stroke, we've got a number of metrics that continue to improve in months, which is really positive. However, we're all acutely aware that the service remains volatile due to the fragility of the service model and the sheer volume of patients that we are getting through. Workforce consultants plan is stronger than it's been for some time, with the recruitment of some locum support, which will sort of help the short-term position, and then the conversation around the medium-term and regional longer-term plans have recommenced. We're also looking at how we can bolster up the AMP and the SNAP coordination key roles to support the delivery of the service on a more sort of 7-day model, and obviously improve the way in which we collect the data for those services. In terms of diagnostics, the target to be 0 by the end of December. I'm pleased to say that the backlog position continues to improve. MRI waits over 8 weeks are now nearly eradicated, and we'll see the MRI mobile ending this week, with a switch to the CT mobile coming into place this quarter, which will run 12 hours a day, 7 days a week, to start reducing the significant CT backlogs. All that in parallel with the work that we are doing around the management of the demand coming through, which seems to be rather excessive at the moment. Non-obstetrical ultrasound and echocardiograms all on track to deliver to plan. Neurophysiology, we're working on a tactical solution with Swansea Bay, which we continue to manage, and therapies continue to perform well and are on track. Cancer, we recognise that our SCP target is off trajectory. We've had a very consistent operational approach to focus on the backlogs of clearing the 62 and 104-day waits. We've seen a clear reduction across all care groups, so that approach is working. But obviously the caveat to that is it does impact on the overall performance. We remain on target, however, for 60% by the end of December, so that's really positive, and we are confident in the mitigations we are putting in place to strengthen the SCP pathway. We know that diagnostic and outpatients and tertiary delays remain a significant factor, and working with other stakeholders to improve that position is key within all our plans. We're seeing sustained improvement in urology. LAPBs have now moved into RGH, and we are less than 2-week bookings now. And breast investment, I think, is certainly coming into fruition because we've seen a real sustainable improvement in breast services across CTM as part of that. So again, all really positive. Planned care, we've delivered 156 plus by August as per plan, and I think it's really important to note that we're the only health board in Wales that's achieved that. So credit to the teams for delivering that to plan. 104-week waiters, we're confident we can deliver to trajectory. The only caveat to that remains a concern is ophthalmology. Cataracts in particular are a concern, and we have a new CD that's appointed into post, and we continue with the regional discussions around how we mitigate the risk of long patient waits and patient harm. I think it's important to note there that we're not an outlier. Obviously, it is a national problem, and one that we feel that we are making some progress with in terms of the mitigations. Follow-up not booked. We are relaunching the outpatient transformation improvement work as part of the PIT programme. We've got a specific work stream that will be focusing on outpatients, and we will be starting at the beginning of November with a sort of webinar stroke lecture theatre session with Ken Harris, who's the national lead for outpatients, who's transformed the way that they deliver follow-ups in Hywel Dda. So I'm in the process of creating a session for all our medical clinical teams to really kickstart our approach to how we manage follow-ups in the organisation. In parallel with that, we're looking at all validation opportunities. We're working with IT to understand how we can apply logic to the backlogs. So overall, we are looking to show an improvement in the follow-up position through those work streams as we progress into the next couple of quarters. So in summary, that's very quick, I know, for such a large document, but they're the key points that I wanted to extract for today, and I'm happy to take any questions.
Thank you, Sarah. What I will do is I'm going to ask colleagues to hold on to their questions until I've asked other exec colleagues just to present their bits of the report. So if that's okay, what I'll do is I'll go to Greg next, and then I'll go to John. Thanks.
Thank you, Chair. Okay, so I just want to talk through some of the IP&C metrics on page 31 of the report. So our C. difficile rate, so C. difficile is that very unpleasant foul infection, has started to level out. It's been a cause of concern for the last 6 months or so, both for us and across Wales and in fact the UK. Although our rates per 100,000, so I put some benchmarking information in the report this time. So our rates per 100,000 population is 36.53, which compares to the All Wales rate of 50.66. So we're a positive outlier in that regard, but nevertheless, we've still got some work to do. It's still around 60% of our C. difficile cases are community onset, so quite difficult to influence in that particular point. But nevertheless, we have seen a reboot of our antimicrobial resistance work since we've changed the clinical model of pharmacy very recently. So some of the main causes for C. difficile are broad spectrum antibiotic usage, and antibiotics not probably being stopped when they should be, but also some gastric suppression medication. So they're the two reasons why C. diff generally happens. So lots of focus and attention both within our health board, but equally across Wales on reducing the levels of C. diff. I am pleased, though, to report again, still on IP&C metrics. Board members may recall some of the concerns we had around some of our gram-negative bacteremias last year. So E. coli and Klebsiella infections specifically. We put lots of attention on urinary catheter care and invasive line care last year. We have seen the benefits of that now. So both those gram-negative bacteremias are tracking below last year's performance. So some improvement within that space, which is really positive. We do see some lapses of effective hand washing, bare below the elbow, and PPE usage through some of our audit work. So there's been particular attention, and this isn't just one professional group, it's across the professional groups. So we have put some more messaging out with regards to challenging in the moment. So if you're out on a ward area and you are seeing practice that doesn't comply with our hand washing or bare below the elbow or PPE policy, it's to respectively challenge in the moment, which can be challenging sometimes, certainly for some of our lower banded staff when there are some very senior clinicians walking around, but nevertheless a big focus on that, and the clinical execs have sent some comms out to our colleagues. So we're in a pretty good space with our IP&C targets, but we still need to focus around C. diff. And then just back a couple of pages, so 32, this is around our serious incidents. And again, we were struggling. In fact, we were bottom of the league table across Wales in relation to some of our legacy national reported incidents. So at one point we had 49 of these over the 90-day target. The team have put a huge amount of work in. It's nice to see now where we're rising up the league table in a positive way. So we still have 37 legacy serious incidents that have gone over the timescale for various reasons. I think the most important thing, just to assure the board, is that when an incident happens of a serious nature, there is a rapid review that happens within 72 hours and mostly 48 hours at the point of incident. We do then put any immediate make safe actions in place to mitigate any further issues, and then we follow the investigation process. Every person that is involved in an incident from a patient or family perspective, we do offer them a family liaison officer. So even though we may be going over the 60 or 90-day target, we're still in contact with these people that have been affected, and we really encourage them to actively participate within the incident. So at the point of incident, when we have that initial discussion with the family member or the patient, we do ask them for any questions they would like addressed during the incident process. Some don't want to be involved, but actually most people do. So we still got some work on working through those 37 serious incidents that remain over the compliance target, but nevertheless, we're definitely in a better space than what we were previously. So they're the two things for me, Chair. I think I'm handing to Lauren to talk to some of the metrics.
Thank you.
Metrics.
Thank you.
Thanks,
Yes. So only very brief from me. I think there's some good quality information in this report that gives you a lot of the narrative that you need, and Sarah's helpfully gone into detail around a couple of the areas. So around stroke, as Carolyn said, this is an area that gets lots of scrutiny and discussion in a range of forums. So just wanted to give the board some assurance around the level of scrutiny that we've got on our stroke services. I think what we are seeing is a sustained increase in the number of strokes presenting, which is a challenge. What you'll see in the detail here is some helpful information in terms of the numbers presenting in the evenings and the weekends. And I think what you see then is the impact of those out of hours presentations on our quality metrics, because our model, as we know, currently is a Monday to Friday 9 to 5. So obviously, as Paul said, we'll be having conversations around our stroke services and what else we can do. Good news in terms of the recruitment of a locum, and there was a specific focus on the stroke pathway within POW during the reset fortnight that Sarah also mentioned. And then with regards to our healthcare scientists, the diagnostics page, you'll see that some good progress has been made there in terms of reducing the number of patients waiting over 8 weeks. So a big input from our healthcare scientists and the whole MDT. An increased demand in radiology that we're continuing to see. So the team are looking at what our options are there. And then the allied health professions, lots of work over the past 12 months to reduce the 14-week waits, so they're minimal. And good performance as well in the reducing the 14-week waits for children. And then with regard to therapies, we had a good discussion in OMB recently regarding the AHP staffing establishment and their vacancy numbers.